If not, then if people come in, maybe go to second time somewhere.
I would at least. That's a word.
If you think that people are hearing. Yeah.
Okay, so just start.
If you guys have it.
Now I know.
Yeah.
Yeah, I don't care. Yeah, we can't.
Okay. This one right here, 7.
The garden one,
The other judgment has been emergencies. So you feel like you can be judgmental enough for 2 people? Is that gonna be hard? I think we've exchanged lots of emails. How many eggs? Can we use? If I can get it done. I'm back. But it's like I know what? There was a change. I did. Sorry, there's going. So we have to compare nine to the year. We rethink and start looking at our out and then one. And there's a one. The capital. Yeah. Are they doing this?
Oh, yeah, it's the bottom.
So.
Are you? Good to start? Okay. Hey, I'm Tucker, the MC for this room. We have some QR codes up here. It'd be great if y'all scan it at some point. And let's see. There will be a timekeeper in the back, and the student will hold up a green sign when you have 5 minutes left, a pink sign when you have 2 minutes left, and a red sign when your time is up. And we could, if we could hold questions until the very end, that'd be great, the end of like each presentation. And up next, we have Abby Hayes on the influence of premature birth on ADHD incidence.
So like you said, I'm doing the influence of premature birth on ADHD incident. How do I full screen it? Here. What now? Thank you. So ADHD is a neurodevelopmental disorder, which is highly prevalent here in the US. It can be seen as inattention, impulsivity, or hyperactivity. Symptoms usually occur in young children or those that are in school age. And then as we probably know, premature birth is 37 weeks or before. And during this time, they endure many environmental factors that can cause stress while their systems aren't fully developed yet. So with that being said, ADHD seems to be more common in babies that are premature, possibly from these impacts of outside factors while still trying to develop neurologically. In my first article, it looked at performance monitoring and its association with ADHD symptoms in premature babies. And it used a population-based quasi-experimental study. It had 390 individuals from secondary schools, with 194 being premature, 93 having ADHD, and 166 that were controls. These requirements that they had to get into this study was that they couldn't have an IQ that was less than 70, difficulty learning, cerebral palsy, or other conditions that might affect their motor coordination, or that might look like ADHD itself. Limitations that they had was parental reporting and the inability to completely rule out possible background risk factors for premature birth. A strength that it had was that it repeated IQ as an independent variable to observe IQ as a potential contributor to the study's results. Its results showed that the premature group's results were drastically higher than the control groups and showed neurophysiological impairments from both error processing and conflict monitoring. In the second article, it was for the goal to determine if premature birth or other risk factors increase the risk for cognitive neurophysiological impairments in ADHD in children born premature using non-randomized quasi-experimental study. It had 104 premature individuals and 104 of their term-born siblings. Some requirements that it had was that the participants couldn't have an IQ less than 70, other medical conditions that affect motor coordination, or brain disorders or medical disorders that appear like ADHD. Limitations was that it consisted of age differences, different sexes, birth order of siblings, as well as subjective rating of parents and specific maternal risk factors between the two pregnancies. The strength was that the two groups were made between siblings, and it decreased the idea of genetic bias results. The results showed that premature birth had a significant impact and increased ADHD symptoms, IQ, error processing, and preparation vigilance measures. In Article 3, it looked at possible association of gestational age and ADHD in children at 5 and 8 years old, as well as the difference influenced by sex using a cohort non-experimental study. It used 113,227 individuals with 55,187 females and 31,708 being born at 40 weeks. As well as they also had 33,081 siblings with 16,014 being female and 9,705 being born at 40 weeks. Limitation that it had was 41% only participated. And a strength was the sample population side and the size and the age difference statistics. Results showed that children born premature showed an increase in ADHD, inattention, and hyperactivity, impulsivity symptoms compared to those born in term. Article 4 is that it investigated the possible relation of gestational age to ADHD in those with Down syndrome that were born at 35 weeks or after using a cohort non-experimental study. It had 105 individuals with Down syndrome and 49 were males and 56 were females. And those age ranges were from 6 to 18. Requirements that I had was that the individuals couldn't have other chromosomal anomalies and be born before 35 weeks, have epilepsy or seizure history, or have head injury or chemotherapy history, or have hearing or vision loss. Limitations was that trisomy 21's influence on brain development, ADHD presenting in a wide range of symptoms and degrees, different severities of Down syndrome, services being given, and methods of determining gestational age and maternal reporting. Strengths, all individual symptoms were based on using the same Kohner's parent rating scale, and initial analysis was done to observe for the need to adjust for other potential factors. Results showed that the age of gestation had a relationship to the T-scores of hyperactive, impulse, and inattention subscale before and after looking at the age of individuals during ADHD development. It also showed that the earlier the gestational age, the more ADHD symptoms those with Down syndrome had. Lastly, Article 5 differentiated between ADHD on the idea of symptoms, course, prognosis, and clinical features that are associated in a high-risk population of low birth weight and premature individuals using cohort non-experimental study. It had 387 members that were considered within the low birth weight and preterm population that were all evaluated at ages 6, 9, and 16 for ADHD. Requirements was that it wasn't classified as having any major motor or cognitive disabilities by 16. Limitations were the use of self-reporting questionnaires of individuals using DSMR symptoms criteria for assessment at ages 6, reliance on parents for ADHD symptoms report assessment, and family risk factors, and the absence of information on autism spectrum disorder before 16. Some strengths is that the method of using the individuals evaluated for ADHD at the 3 different years being 6, 9, and 16. The results showed unaffected class, showed modest inattentive and hyperactive impulse symptoms at age 6, but declined by age 9. School age limited class had relatively high inattentive and hyperactive impulse symptoms present at age 6 and 9, but declined by 16. And persistent inattentive class had high inattentive and hyperactive impulse symptoms with high inattentive symptoms persisting past age 16. In conclusion, a vast majority of the literature indicated that there was a relationship in the increase in ADHD incidence as a result of premature birth. Proper lifestyle techniques to prevent these preterm labors, as well as limiting external stimuli to prevent infants from during the neurological development, can reduce the incidence of ADHD. It is also important when taking care of pediatric patients that you gain the full birth history, as it can be helpful in the care and diagnosis of possible ADHD in children. ADHD can affect academic, professional relationships, or daily functioning. Early diagnosis is very important to those children with ADHD, as there can be things implemented to help them excel in school, such as the setup of the classroom, teaching techniques, and modified curriculum. So it is important for us to know the possible disorders that can come from premature birth, as well as a detailed birth history to assist in early diagnosis later in life. And those are my references. Any questions? Do you have any questions? You good? I had never thought about the relationship of ADHD and premature birth, so I was honestly surprised by it. And I learned a lot from researching it. So yeah.
They find in relation between how early the birth is. Very low. Simple parenting and what.
there wasn't many research about that. Thank you. Anybody else? Go ahead, okay with that?
Yeah.
Abigail Martin.
Yes.
Okay. Up next we have Abigail Martin presenting on, the. In the postpartum patients, does unit transfer influence patient satisfaction?
No, it's gonna be on, there should be a USB drive out of it. Should be a USB drive on it. Yeah, why is it not on?
Have my own question.
No, it's got, it's supposed to be pulling it from the flash drive. And
If everybody's getting QR code.
that is weird. Hold on. They had it already pulled up when I came in. Let's try that. No, it's not that. It is not recognizing that drive. Abby, did you have to, where did your PowerPoint pull up on the USB drive? Because it's, I can't find the USB drive. Let's try something else here.
So I can send it to you though. Why it emails you, but yeah.
Okay, so it is under C users presentation.
It showed like 9 o'clock and then it showed on 4 bars.
See if I can reverse this. Desk presentation, desktop. That's what I'm looking for. Desktop symposium presentations. Okay, let's not lose this folder. There we go, 9 o'clock. All right, which one is you?
That one's mine.
Okay. Oh, it's in order. Look at that.
Okay. Okay, my name is Abigail Martin or Abigail Martin Ledbetter. I don't know if it's changed in the system yet, but okay. I'm a senior nursing student and I did evidence-based presentation on postpartum unit transfer. So in America, the population of women are starting to be looked at more, but to better serve women, America needs to look more towards women's healthcare. A big part of this healthcare is the process of childbirth and the healthcare services and practices that go along with it. In America this year, over 4 million babies have been born. This means that around that many women have experienced the healthcare associated with prenatal and postnatal care. Throughout the nation, many hospitals have progressed to having separate labor and delivery and mother-baby units where women will deliver their babies in a different room from where they will experience the remainder of their care after childbirth. Although healthcare has progressed to this setup, it has yet to investigate the impact that this transfer of care has on the women. So my PICA question is, in postpartum patients, does unit transfer influence patient satisfaction? So for the population, we're looking at postpartum patients and the outcome is patient satisfaction. So our control is unit transfer. My methods of data collection, my data was collected for this literature review using websites such as the National Library of Medicine and the Cumulative Index to Nursing and Allied Health Literature. All literature is dated within the past 10 years and is evidence-based scholarly articles. After researching this PICO question in these databases, the conclusion of 5 articles came out to best answer the query. So my first article was titled Women's Experiences of Transfer from Primary Maternity Unit to Tertiary Hospitals in New Zealand, which was part of the prospective cohort evaluating maternity unit study. The authors were Greg, Monk, Tracy, and Smead, and it was published in December of 2015. It is a concurrent qualitative typology, which means it is a meta-analysis. There were 702 pregnant women who were looked at, and they were booked to give birth at a facility in New Zealand. The observable measures are the survey questions and open-ended survey questions that they used for this study. So some strengths that this study had was broad responses because of the open-ended questions. It interpreted the feelings and assumptions made while also facilitating numerical data, and it took into consideration that there is more than numerical data that should be collected. Some limitations was that it had a small sample size, it used only survey data, it used only healthy pregnant women and did not take into consideration the thoughts of other women, and it was conducted in New Zealand and not America. So the evidence was a level 2 because it was a meta-analysis. So my findings relevant to my PICO was women understood the potential for plan of change or transfer and appeared to be more unhappy about the decision to change birthplace or transfer than the transfer itself. And then caregivers who enable women to maintain a sense of control, communicate respectfully and effectively with women, and provide support and information to them may facilitate a more positive experience of transfer. My second evidence piece was client experiences with perinatal health care for high-risk and low-risk women, and it was published in December of 2018. It was a quant-qual typology, also a meta-analysis, and it had 1,388 women who attended well baby visits within 12 weeks after their childbirth, and it was conducted in the Netherlands. It was used, they sent out a questionnaire that was then compared as a multivariate data to other studies. It had a very large sample size. It was very quick to analyze. It incorporated both high-risk and low-risk pregnancies. There was a high response rate to the questionnaire, and it was validated with the ReproQ questionnaire, which is like a questionnaire study that they use over in New Zealand and places like that. So some limitations it had was that it was a Dutch study. It had sample bias. There was no follow-up on those who failed to return the questionnaires, and data was reported by the women, and the women may have had bias. It was also a level 2 meta-analysis. So the findings relevant to my PICO question was we found that women with a high-risk pregnancy and or childbirth had a less positive experience with perinatal health care than women who had a low risk. And the study identified variables that were associated with unsatisfaction for delivery and healthcare associated with it, such as high-risk pregnancy, a non-Dutch ethnicity because this was conducted in a Dutch area, an unplanned pregnancy, an unplanned medical intervention during childbirth, pain medication during childbirth, and unfamiliarity with the healthcare provider who guided childbirth as risk factors for developing notably bad experiences. My third evidence piece is through the professional's eyes, transfers of care during pregnancy, childbirth, and the postpartum period. So this article is through our outlook as nurses and professionals rather than being through the patient's outlook. It was published in February of 2020. And it was a Venjet study, a qualitative experimental interview. So they interviewed 4 community midwives, 4 obstetricians, 4 maternity care assistants, 3 youth healthcare nurses, and these were all in the Netherlands again. And the observable measures were interviews, and a vignette study was conducted after the initial interview where they would give the healthcare worker a certain scenario, and the healthcare worker would have to work through that scenario. So some strengths was that it had different clinicians throughout obstetrical practice to get the opinion of all, and it helped to understand the outcome of unit transfers from the clinician's view, and it used purposive sampling. Limitations is that it had a very small sample size. They only used interviews, and it was conducted in the Netherlands, not the US, and it used purposive sampling. So that could be strength and limitation. The evidence quality was a level 3 and findings relevant to the PICO. The participants all explained that they know of mentioned 10 risk factors that impede continuity of care, which includes multiple locations, acute situations and high workload, language barriers, night shifts, different hierarchical levels, not knowing who to contact, insufficient knowledge of protocols, usage of different registration systems, and communicating in acute situations and honoring privacy. Clinicians mentioned that more research needs to be done in providing regular multidisciplinary training sessions on transferring clients by using protocols, especially in acute situations. This factor was mentioned multiple times as a facilitating environmental influence and should therefore be implemented as a regular policy measure among obstetric and neonatal healthcare organizations. My fourth piece of evidence was called client satisfaction and transfers across care of levels with women with uncomplicated pregnancies at the onset of labor and was published in May of 2017. It was a populational cross-sectional study and included 842 postpartum women who experienced uncomplicated deliveries. The observable measure was a questionnaire that was sent out via paper or computer to fill out. The strengths was that it was quick to conduct and yielded almost immediate results. It yielded a larger sample of women, but not those who experienced complications and loss of their infant. The limitations is that it only included women attending their first antenatal appointment. It was self-reported, and the measures were good, bad, and they're very subjective, and there was a non-response bias. It is a level 3 evidence quality, and the client satisfaction of women who were transferred across care levels was significantly lower than that of women who were not transferred. And it explains that the difference did not appear to be based off interactions, but that the difference is largely explained by the fact that transferred women perceive more health problems after birth, experienced more medical interventions during childbirth, and had not positive experiences with 5 care process variables. My final piece of evidence is through the client's eyes, using narratives to explore experiences of care transfers during pregnancy, childbirth, and the neonatal period. It was published in June of 2017, and it was a narrative inquiry. There were 17 Dutch women who gave birth and experienced transfers in the Netherlands, and that's who they used. They used a storyline analysis and comparative analysis of narratives written in the paper and typed. The strengths is that it revealed different perspectives and deeper understanding of information, and it helped to represent experiences in textual form. Limitations is that there was a small sample size. It's hard to know what influenced the different narratives that the storytellers are describing. Maybe they could have had a bad nurse or a very bad experience with that person rather than just the experience in general. And it is a level 5 because it's a narrative review. So findings relevant to the PICO is that transfers of care lead to disruption of patient-provider connectedness. Disconnected transfers of care lead to uncertainties. Transfers of care affect clients greatly and influences their experience. Good communication, seamless transfers, and maintaining autonomy contribute to more positive experiences. So, to synthesize the data, the first study shows that women changing floors are more dissatisfied with the decision to do so rather than when it happens. It also helps to show that the caregivers who advocate for their patients and support patient autonomy help to facilitate better satisfaction when it comes to transferring. The second study showed that women who are high risk and experiencing an unexpected birth situation that results in the transfer of care or transfer of units during delivery and after are more dissatisfied with their birthing experience. The third study proves that a change of care has many factors that cause dissatisfaction, including multiple locations to learn, a lack of communication with new clinicians, and many do not know whom to contact when asking questions about care topics. The fourth study conducted that women who are transferred across care levels and units are more dissatisfied than those who are not. The study also explains that this difference may not be based on interactions, but is because those who experience this transfer are typically experiencing a higher acuity birth. Finally, the final study deduces that unit transfers and care transfer disrupt patient-clinician connection and communication and explains that transfers of care significantly affect the birthing experience. Each study summarized that the transfer of care causes dissatisfaction in women after they give birth to a child. So in conclusion, the experiences associated with childbirth need to get more attention. Many studies have been conducted in other countries focusing on childbirth and the experience associated with the childbirth. It is hard to compare the collected information to the American population because of the mixture of cultures, the different types and levels of care, and the differences in the focuses of childbirth worldwide. If America plans to center more on women and in its country and their experiences with healthcare, one of the first things that needs to be investigated is the transfer of care within childbirth. Before the floor change began happening, researchers in America should have glanced to the information provided worldwide that proves this care transfer can negatively impact mothers and children. Women and children in this nation deserve the best care possible, and more researchers need to investigate the impacts that this transfer of care can have on them in the future of childbirth. Okay, and these are my resources. Thank you. And does anybody have any questions?
So were you not able to find, most of your studies are from the,
Yes, I couldn't find any studies in America.
wonder if you have any thoughts on why?
I kind of feel like it was never really looked into. They just started implementing it in general, and they don't really like notice, hey, there's a change of care between these people. Like on the mother baby floor, I've noticed that a lot of patients will be like to their labor and delivery nurse, they'll be like, oh, you're not going to be with me anymore. What? Because they built this relationship with them, and now an hour after they give birth to a child, they're having to change floors, change people they're with, change the like room, change everything, and it's really crazy. So I think it really needs to get looked into in America, but nobody has yet. Does anybody else have any questions? Okay, thank you.
Up next, we have Lindsay Chitwood presenting on substance use in adolescents and prevention programs.
As you said, I'm Lindsay Chitwood, and today I'm going to talk to you about prevention programs that are targeted at adolescents and substance abuse. By 12th grade, 71% of youth in the United States have tried alcohol, 42% have tried cigarette smoking, 43% have tried marijuana, and 25% have tried an illicit drug other than marijuana. That's an alarming number, considering most of these students don't understand the consequences long term. Adolescents' brains are extremely moldable. Commercials, music, social media, all of that makes drinking look fun and sound fun, but I mean, who can name a country song that doesn't involve drinking? And even the Super Bowl commercials now. We really see a rise of this starting in the 60s and 70s with the Woodstock era, but we don't see these programs really being implemented until the 1980s. Even with the implementation of these programs into schools, we still see a rise in substance abuse among adolescents, which leaves the question, do substance abuse prevention programs have a positive effect on adolescent students? The first article I reviewed was a cluster randomized control trial that was initiated in 2012, evaluating the effects of delaying the onset of substance abuse on cognitive development and addiction. 31 schools were assigned to random and control intervention groups in Canada, and it used personality targeted intervention programs focusing on evaluating the cognitive, mental health, and addiction outcomes over 5 years. High and low risk students were determined using the substance use risk profile scale. Some of the limitations include the geographical location, constituting selection bias, and a strength is the efficacy of the data measurement tool. The results of this article are still unpublished, but internal data points towards positive signs in high and low risk individuals based off self-reporting. The second article I reviewed was a systematic review and meta-analysis that was done in 2018, proposing the question, does integrated academic and health education prevent substance use?
This synthesizes the effectiveness of interventions integrating academic health and education for prevention of substance use. It included an array of databases that were searched for mainstream education, excluding subgroups and trained teachers. The results identified 7 trials reporting substance use, and interventions reduced substance use in grades 7 to 9 and 10 to 11. One limitation is the highly variable evidence quality, the inability to assess publication bias, the involvement of combining estimates across a diversity of follow-up times, and grades 3 through 6 and 12 through 13 were not analyzed. The results show that 53% of people who receive intervention will have lower levels of substance use than the people in the control group. And it also predicts that early prevention of substance use could decrease the risk of harmful patterns of drug use in the future. The third article that I reviewed is about the positive effects of the Rational Addiction Prevention Program, or RAP, on adolescents with a high risk for drug consumption. This was conducted in 2021 in Mexico with students ages 12 to 15, and it aims to determine the effect of RAP on the behavioral and cognitive characteristics of adolescents with high risk for substance use. The study assessed resilience, social skills, attitude towards substance use, ability to delay a reward, and inhibitory control. There were 38 high-risk students and 38 low-risk students, so some of the limitations included limited sample size, but the strengths were vitality of the screening tool. The results of this study showed effective in preventing these risk factors in high and low-risk students. The fourth article that I reviewed was a study conducted in 2022 evaluating the integration of the screening, brief intervention, and referral to treatment screening into school nursing practice. This was a Q1 project assessing the effectiveness of the SBIRT, and it was conducted at a boarding school consisting of 404 male students, although it focused mainly on the nurses. 6 school nurses participated in the study and reported self-efficacy levels that increased in using the SBIRT process post-education. Some limitations were that it was a Q1 project and not a formal hypothesis-driven research study. There's a lack of diversity, a potential for unintentional bias, and some of the strengths include contribution to healthcare milestones. The results show positive outcomes as the SBIRT tool was used in another study consisting of 629 students and found that there was a decrease in the incidence of drinking and drug use after 6 months. The fifth article is a qualitative review that was conducted in 2019 discussing the content of alcohol and drug prevention programs targeting adolescents and grouping it into 5 major types. The 5 types include information-based primary prevention skill training, universal or primary prevention family components, targeted approaches incorporating skill training components, and approaches incorporating digital features. There were 33 peer-reviewed articles, and the most common of that was the universal skill trainings approach. The limitations to the study were uneven distribution of the studies, inclusion of the studies on approaches only aimed at 12 to 20, and none of the articles pay attention to age-specific groups. Some of the strengths include recognition to skewness towards primary prevention skill training approaches and the need to further these research interventions. The results show an indication of strong representation in the skill training prevention style, but are inconclusive on which category has a positive or negative effect on students. And the last article that I reviewed was a meta-analysis that was done to determine the effectiveness of Project DARE. DARE is one of the most widely used programs targeted at youth in the United States. Most of us probably went through the DARE program in here if you were in Georgia. 11 studies included the pre and post intervention assessments, control groups, and consisted of peer-reviewed journals. 4 of these studies concluded that there was no effect in relation to the control group. 1 study noted DARE to be less effective, and 6 reported positive effects, although small and mainly on smoking. Some limitations to the study include the students were the unit of analysis, which can lead to overestimates in the program effectiveness. And it also analyzed the old DARE program, which has since been replaced. The results actually show that the DARE program was ineffective in preventing substance use in adolescents. In conclusion, the overall results are positive, negative, and some are inconclusive, but most of these studies were done on small sample sizes and are based off of self-report, which can lead to skewness in the outcomes. The literature also primarily focuses on Caucasian communities, which leaves us questioning, would the outcomes differ with the inclusion of minority communities? Implementing these screening tools into nursing practice could allow for early intervention with adolescents struggling with substance abuse. This could also allow for us to screen children on a regular basis based off risk factors, to implement secondary prevention measures, to ensure the health and safety of the child. Implementing these prevention programs all throughout an adolescent's primary schooling can serve as a reminder of the harmful effects of drugs on the body, but also what to do in case of an overdose. These problems aren't going to resolve themselves. Therefore, we must ask ourselves how. Should we create a universal substance abuse program, or should we just adjust the curriculum of these programs to target more current youth? Our question is answered inconclusively on if substance abuse prevention programs have a positive effect on adolescents, which means more research should be conducted to determine the best program to implement. And those are my resources. Any questions?
When did you decide to do this?
Oh, Lord, I have a deep personal connection with this kind of stuff. So it hits home just to think about all the kids that are out there that are, 12, 13 years old that are doing drugs and that might not have had a choice in it, and they don't deserve that. So, yeah.
So the results were inconclusive, and I know, but of the different preventative measures that you looked at, if you were to make a recommendation to the school nurse, which one do you think is the most effective?
I'd probably go with like the expert one, just because it's already implemented into like a nursing practice, so it's tailored towards us. I feel like most of these prevention programs are tailored towards law enforcement, and law enforcement's a lot of the times who does these programs for the schools. So if we had something that we could implement in the school nursing and also just in nursing in general to help identify these students, then I feel like that would be a big difference. Yes, yes.
Thank you, TR Daily, doing on mental health and mortality in American hospitals.
Yeah. Oh, yeah, there you are. You want to go ahead and pull up the
Yes,
video that
it's
you
right
don't
here.
from? Okay, perfect.
I got it ready to go.
All right. So we are all good then. Share your screen. We're gonna do that one. Ooh. Okay, I don't know how to share. So we're just gonna kick out. Okay, but I'm all right. There you go. Okay.
Hello, my name is Tiara Daly, and I will be talking to you today about maternal health and mortality in American hospitals. So the question that fueled my research really is, are non-white Americans at greater risk for maternal death when compared to white Americans delivering in American hospitals? So I'm gonna I'm gonna share a story with you, but before I do that, I have a few questions so we can get to know each other and it won't be so intense. You just raise your hand. My first question is, how many of you one day would like to have kids or have kids right now? So I do not have any children right now. I just have 2 fur babies, but I'd like to have kids one day. How many of you know a woman or are women that may be frightened or nervous about potentially delivering one day? I am traumatized by the thought of producing a tiny human. And so how many of you, even though you are frightened, still have peace and excitement when you think about delivering a baby? Great. So I cannot raise my hand to that. And that is really the motivation behind. So I'm going to share a story with you about 2 women. And I'm going to attempt to come out of this. All right. So a short video. Okay. You want me to pause it? Okay. Make sure it's showing.
You're good, you're good. I don't know how to use it. We're gonna stop share. We're going to switch to that. You ready? Good, yeah. Okay, here we go.
Now, with the documentary exploring the U.S. maternal health crisis, 50,000 women each year have unexpected outcomes of labor and delivery, and 2/3 of pregnancy-related deaths are preventable. Those most at risk, women in the Black community, and Robert Roberts focuses on families that are experiencing these devastating effects.
Losing a partner was then having to turn around. This was a new document spotlighting the U.S. maternal health crisis. Losing their longtime partners due to childbirth complications. Their dreams adjustment featured in the aftershock. When I said I was in the cell before you all were on your own and you're sitting on steps, and you could really that he knew what it was you were doing. And nobody else but somebody who's been in that path and understand it. I want to find out more about your mothers. Thanks. In October 2019, following a C-section, Shalani Gibson spent 13 days with her newborn son before she suddenly passed away. Tell us about those 2 weeks, what they were like. What she gave her. What we got home, she was about chest pain, she had a cold and lunch, everything was working, so called back, but we had a big hospital. Times where Shivani tragically suffering of pulmonary embolism, a blood clot in her lungs, which her family claims was preventable. Guilty, but they're not realists. Black woman, and I talk about this all the time. A lot of my daughter be exempt, her mother, and reproductive rights activist Shawnee raised awareness of specific challenges Black women face during and post pregnancy.
Our wombs create worlds, and we can't trust and believe that we can birth safely. Women staying on the planet, Black women are 3 times more likely to die from pregnancy-related deaths than white women. 60% of these deaths are preventable.
46-year-old Amber Rose Isaac passing away after an emergency C-section and what Bruce called months of ignored high-risk symptoms. The complications that started was the 2nd and 3rd trimester occurred. What was going on? She was having chest pains. Amber's family currently in an ongoing lawsuit with Montefiore Hospital, which has denied any wrongdoing. The hospital releasing a statement earlier. Montefiore's maternal mortality rate of 0.01% is lower than both the New York City and national averages. Any maternal death is a tragedy. Our hearts go out to Ms. Isaac's family, especially to her mother, our longtime colleague.
Okay. Okay, and share again. Share. And. There you go.
Mary Jen, thank you so much. Okay, so these two stories are extremely heartbreaking, but they're really not uncommon. So I'm going to talk to you a little bit more about the statistics. Black or African-American women had the highest death rate per 1,000 live births. In 2014 to 2017, Black women had a mortality rate of 42, whereas white women had a mortality rate of 13. The mortality rate among non-Hispanic Black women is 3 to 5 times more than their counterparts who are white. The leading causes of death among non-Hispanic Black women were eclampsia, postpartum cardiomyopathy, and preeclampsia. So I mentioned those causes, but I'm going to tell you a little bit more about them. If we understand what is causing these women to die and how preventable and treatable they are, then maybe it will cause a little bit more action. So postpartum cardiomyopathy is a disorder in which your heart becomes enlarged and therefore weakened. The signs and symptoms would be like cough, waking up often at night to use the bathroom, swollen neck veins, and fatigue. The treatment for this would just be drugs. The next one is postpartum hemorrhage, which is indicated by an increase of vaginal bleeding and low heart rate. The treatment for this would just be a fundus massage, drugs, fluid, or potentially even surgery. The next one is pulmonary embolism, like one of the women who we just learned about. The signs and symptoms of this would be shortness of breath and chest pain. The treatment for this would be just blood thinners. And then preeclampsia or eclampsia, this is displays itself as swelling in the face, headache, swelling in the legs, or weight gain of 2 to 5 pounds in a week. The treatment for this would be drugs and delivery. I thought it was important to teach you guys about, these disorders because they aren't anything that requires any extensive type of attention. You can look at somebody and see if they're short of breath. You can see if they're having difficulty walking or if their legs are swollen. They can tell you if they're having chest pain. So the problem isn't necessarily recognition, but we're just ignoring them. The research shows that 60% of these deaths are preventable. And when we think about the statement that the hospital made, 0.01% people die. I think that no women should be dying of things that should be preventable. So using the advancing integrated models of care can create a really empowering experience for doctors, nurses, and their patients. With this approach, we can expand who is caring for the people, like doulas, midwives, more nurses, social workers, community workers. If we have more people with their hands in it for healthcare workers that are already spread thin, then we will have probably a lower chance of patients dying as a result of childbirth. So as I was researching and reading the articles and going through my clinicals, I realized a few things that services like Medicaid would provide more opportunities for people to get things like doulas and community health workers. These mothers need a more interdisciplinary approach, and they also need patient education to know that this is not normal. If you don't know what to expect, like many women who haven't had babies, then you don't even know what to ring the alarm for. So, in conclusion, the issue of maternal mortality of Black women in the United States is a problem born out of many factors. While Black people in this country have always been on the receiving end of failing social institutions, maternal death has been far less researched. From the available studies, it is shown on this front that Black women in America are highly discriminated upon and then pushed toward death. And holistic disciplinary approach is needed to remove the title from the United States resume of highest developed world with the highest mortality rate and highest mortality death rate. Thank you so much. Any questions? Yeah.
Did this, presentation really impact you when you were doing this?
Yes, so when I first came into nursing school, I was convinced that I was going to go and take care of pregnant women. I think that pregnant women should be worshiped because they are going through such a challenging time. But while I was in there, I also felt like I wasn't really welcomed in there. Like it's not a place for me, and therefore it's not a place for my people to receive care. And so it does really hit home for me.
What kind of, so this is fairly, you were.
Yeah.
Any research on this topic and what, like you didn't go to the article, so what kind of research did you find on this?
I had a lot of trouble finding research. What I noticed was a lot of people were starting to do the research or starting the studies, collecting data, but just becoming uncomfortable with results. And so a lot of things weren't finished or followed up upon. And then there weren't a lot of questions about why. So originally, like one of my articles focused on the impact of like how, I don't even know how to say this, how African Americans take care of their bodies in general. Like, you know, that we are the highest for diabetes and hypertension and all of those things. And just because I'm a woman who has diabetes doesn't mean I'm going to stop having diabetes, you know, after I have my baby. I will probably have diabetes then, which will lead me to have greater risk. And so you would think that professionals would provide more attention because I am at higher risk. But what they noticed is that even though they were high risk, there wasn't attention given to them. Yeah, very much so. Yeah. No, I don't have diabetes. I am afraid of diabetes, but it is very prevalent in the African American community, diabetes and hypertension.
Oh, that makes sense. I have type 1 diabetes. I'm kind of worried that when I get older and become an adult and I'm having a baby, I'm starting to feel like maybe my child would have type 1 diabetes. Thinking about what's in it.
Right, and so, you know, we need people to come alongside people like you and people like me and partner with us to create a safe atmosphere for giving birth so that we can feel comfortable, we can trust our medical professionals. But, you know, oftentimes we go into the OBGYN and I don't have an OBGYN that necessarily looks like me. So how is she going to know what my skin is supposed to look like or what it's supposed to feel like or how I'm supposed to feel? You know, they just don't know because they're just unaware. And until we become comfortable with the fact that we are different and attend to that, and that's okay, then there probably won't be any change in the way that we need it. Anyone else?
Asking the session form, every QR code.
So you're under.
Yeah.
Does anybody else want to scan in for session 1? We're gonna change out. Oh, good. Session 1 over. I don't know what yeah, hopefully it continues, but it's not. So I. That's why. But in the. Yep. Yeah, they asked session cannons or. Oh, okay. Even for the. So like. They really show you how to work everything.
So just in case they need any help, and I'm here too if you need it. I've already got the 4 presentations for session 2 pulled up. And then once they pull up their presentation, They'll just need to share the screen and click on that. Then I can resources. So you just do your MC thing and we're good. We finished up a little early from session one.
So
So
like, yeah, I'm kind of, just what are you exactly going to do?
you can just stand up and say who the next presenter is and what the title of their presentation is. Yep,
And
that's
will
all
that
you
be
gotta do.
short?
Let's see. That's a good point. I'm not sure where. Hold on. Okay, yeah, go ahead. Up here in the program. So you're gonna be, those are more presentations for session two. So, introducing each presenter and reminding people to scan in on the QR codes, which are located here and then by the door over there. Lead the applause after each presentation. There we go. A wave.
And when they come up here, you go ahead and sit down.
Mhm.
Okay.
Yep.
He's got a mom.
Open her presentation, the first one. Just because I don't have anything better to do for 3 minutes. I don't know, Brianna? Brianna Gibson? Okay, you don't, you can sit down. We're just making sure you were here. He had a good idea to check and make sure. Okay, so just, do you know how to share a screen?
On the Zooms at the bottom.
Yeah, so you're just gonna do share screen and then click on the PowerPoint. And that's it. And they may not know how to start the PowerPoint. So
You want to stop share.
we'll just click stop share there. That's it. Yeah, that's it. So we'll just leave this up until she's ready. Okay.
Yes, this is Brianna Gibson. Sorry, Brianna Gibson. She's gonna be talking about family witness CPR and what are the effects.
Okay. So my name is Brianna. I'm going to be talking to y'all today about family witness CPR and the effects that it has on healthcare professionals and also the families of the patients who undergo CPR. So I'll kind of go back and forth between CPR and resuscitation, but either way, it means the same thing. So I want to start out with a question. If y'all will just raise your hands whenever I ask. If you had the option to be at the bedside while CPR was being done on one of your family members or a loved one, would you stay at the bedside? If you would stay, raise your hand. If you think that wouldn't bother you. Okay. And then if you had the option and you would choose to leave the room while that was happening, raise your hand. Okay. All right, so the PICO question that I'll be talking to y'all about today, what are the effects of family witness resuscitation on healthcare workers and the families of patients? So Article 1 is an exploratory study that used a semi-structured interview. They asked any nurse who has gone through family witness resuscitation to come forward and just talk about their experiences with it, describe any issues that they had with it. And so a total of 6 critical care nurses came forward between 26 and 48 years old, and they had between 4 and 20 years of experience. So they used a structured interview to just ask about their experience with it and what they thought. And all of the nurses who experienced this reported additional stress while the event was going on, a lack of confidence in their abilities. They just kind of felt like they didn't do everything that the family probably thought they could have. And then an inability to maintain composure during the event. So they just found it hard with family being in the room. While they're not being able to hold it together, they also could not hold themselves together. So some limitations of this were that it was a very small sample size of only 6 nurses. All the participants were female. The study was based in the United Kingdom, and that is a good limitation because they may practice medicine differently over there than we do here in the United States. And then they did not discover any new information. They just reinforced what they had already previously studied. So Article 2 is a systematic literature search that concentrated on emergency department staff. So they were just trying to gain an understanding of the effects that family witness resuscitation had on the ER staff. And what they found was that allowing family members to be in the room while CPR was happening created additional concerns of litigation being brought against them. If the family saw something that they thought was done improperly, that there would be retaliation, a lack of family support. So there was no nurse or healthcare provider in the room to kind of talk through the family, let them know like what was going on. And then a lack of education. They just didn't know how to handle a family member being in the room. And then a lack of policies, because this is a topic that's becoming more and more common throughout the years in healthcare, and we're starting to let families be in the room. So they just don't have any policies on whether they should allow them in there or not. And then the limitation to this study was just that there were no information for the effects on the family. It was just healthcare workers. So now we will kind of shift towards the family dynamic of this. For Article 3, they used a research study to determine if family members who witnessed the resuscitation had PTSD symptoms 1 month following the event. So they had a total of 423 participants. 250 of these were family members who did get to stay in the room and they saw their family member undergo CPR, and then 173 did not. And how they did this was using an IESR scale, which means impact of event scale. And it's just a revised version from what they've had before. So with this scale, they have 22 components that they each rate. It's like a sentence that has a distressing event, and they rate it from 0 to 4 on how much that stresses them. And depending on the score, it can determine how severe your PTSD symptoms are. So what they found were that family members who witnessed their family undergo CPR had higher IESR scores. So it showed that if you watch your family member undergo CPR, you're more likely to have PTSD symptoms afterwards. Some limitations of this were just that it was a convenient sample, and they did not let any people who did not speak English participate. Article 4 used a qualitative descriptive study and a semi-structured interview just to get a deeper understanding of why families resist being in the room during CPR. And a total of 10 of these participants were family members. The other 8 were patients who survived CPR themselves. What they found were that family members fear and resist witnessing the CPR because they don't know fully what's going on. So they were just kind of standing in the corner of the room while all of this was going on, and they had no clue what was happening because they don't have the sufficient medical knowledge. And they said that if there was somebody in the room who was able to explain things through to them and what was going on, that they would have chosen to stay. So limitations of this study were that it was just a small sample size of 18 people. And then a portion of the participants were people who survived CPR, which was not the point of the PICO. It was to focus on family. And then the fifth article was just to evaluate the psychological effects on family members who were given the option to witness versus those who were not given the option to witness. And so 239 of these family members were able to witness CPR and 169 were not. They used a structured questionnaire order of the IES scale, which we previously talked about. And then they used the hospital anxiety and depression scale, and then also the inventory of complicated grief scale. So they combined all these scores, and what they found was that the rate of complicated grief is lower in the family who is allowed to witness the resuscitation. So they were able to grieve easier knowing that all measures were taken. And they were able to be at the bedside while that was going on. And then the rates of bereavement-related PTSD symptoms, depression, and traumatic grief are less frequent if you're able to witness. There were no limitations found to this study. They did not use a convenience sample. They strategically planned out this study. So why is this important to nursing? Like I said earlier, this is a topic that's becoming more and more common in the healthcare field, and some of us in here who will be working in the healthcare profession will probably have to face this one day. We'll be given the dilemma of, do I let the family stay in the room? Do I not let the family? And it's important to know the pros and cons of letting the family stay, and ultimately just giving them the option. At least let them choose, and then just know what could happen. And it's also difficult on healthcare professionals to see a family in that distressing time going through an awful time in their life with their family member, and it just takes a toll on us as well. And for those of you who aren't going into healthcare, this is also something you hopefully won't have to face, but you may have to face one day, where you're given the option to, you can stay or you may, I mean, it's going to be up to you. So I do want to ask, did anyone change their answer from earlier? Would you choose to not go in the room if you raised your hand that you would? Or would you choose to stay instead of not going? Anybody? What would y'all do? Not stay? What about you? All right. Those are my references. And that is it. Y'all have any questions?
So for studies where it was the focused on the nurses, the first two studies that focused on nursing perception and family staying, they did or didn't have educators. One study did and one study didn't have somebody in the room.
Neither did.
Do you think that would have made a difference if they had that like social worker or somebody?
I think it would have. I've seen, like from my practicum hours that I've done this semester, we've done trauma patients that have come in. And yes, like afterwards, there have been family that came in and they're like, for example, last week I had a mom who came in and her son had just been in a motorcycle accident. He was intubated, he had a chest tube, all of these things going on. And she freaked out as soon as she walked in the room, but a patient care advocate came over and like kind of talked her through everything that was going on. And she did calm down a little bit once everything was explained to her about what was going on. So I think it would make a difference. It's just whether the family wants to be there or not.
Maybe best practices, giving them
Giving them the
choice,
option.
and also giving them support.
Yeah.
Feel anything else maybe from this based on your experience this semester?
Yes and no. I still am on the fence about whether I would or not, just depending on how bad I think, because that would be hard to see. But
Yeah.
You are.
Also, I have a short.
Okay.
Are you gonna help me like switch over to screen sharing?
If it's in this, it should be screen shared. Where's the clip?
It's
at?
like the link is right in the second.
Okay, so if, yeah, she has a link she wants to place. so
Okay, so let's go ahead and open that actually.
This one. right here.
Yeah, that's gonna be,
It's-
that to be easier. And then open that microphone down there. Seems funny. I don't think it copied.
Seriously,
I mean, how big of it?
can't get it. How,
Do control click.
control click.
Yeah, if you control click, it'll copy it. There you go. Should copy it, or it should just open it. There you go.
So you want to show this first?
No, not right
Okay,
now.
so you just want to have that up. and-
Yeah, it'll be like,
Okay, so you want to go here.
yeah, and then I'll talk a little bit and then I'll play. Okay, so what you'll need to do is you'll need to stop sharing your PowerPoint and then share your, share Google.
Okay,
I can help you with that if you need it.
yes.
Okay, you want me to stay close?
Yeah,
Okay.
it's just the first slide.
Okay, I'm gonna go right over here.
Okay, thank you.
Randy, you might want to go ahead and get that contract. Restart.
Oh, okay,
You got it?
yeah, let me. Okay. Oh, where's the video at?
The video is on. It's on.
Oh, go to the far right. it didn't-
Oh, okay. Okay.
Thank you.
Oh, no.
Right. Round of applause for Brenda Larney.
Okay, so like he just stated, my name is Brenda Lardy. I am a senior nursing student, and I'm going to be talking about everybody's favorite topic, race. So I'm going to be talking about how does race influence pain management in the acute and palliative care setting. Okay, so I think to talk about something like race in medicine, racism in medicine, it's always important to talk about the history. So I have a short clip just talking about the Tuskegee experiment. I don't know if any of y'all know about it. I'm not going to go too deep just for sake of time, but the video will talk about it. And then I'm also going to talk about 2 other instances of medical racism. And so let me just, oh, sorry. So I say, stop sharing.
I'm gonna change this from.
Okay.
This. That video.
The nation racing went over the unvaccinated and the COVID cases surged. Are you vaccinated?
Not at the moment.
But among some African Americans, fear. What's that?
We've been so many that so many years.
This trust in the medical system rooted in history, like the Tuskegee study in 1932, a 40-year experiment where nearly 400 Black men living with syphilis were denied treatment. Public health officials wanted to see the effects of the disease untreated. As a result, more than 100 men died from syphilis or related complications. Knowing that you were denied treatment and that you were lied to would affect anybody. Common Headquarters' grandfather, Frank Tyson, was a part of the study. There is a lesson in taking broken pieces and turning it into something that's effective and supportive. Turning the pain of the past into purpose. Common and several other descendants were speaking out in a few documentaries, encouraging people to get vaccinated. If you're using the your rationale for not getting the vaccine to protect you. 195 million Americans received at least one shot. Only 10% are African American, but Black people are 2 times more likely to die of the disease. It's a reality that his home, where Cornelius Daniel, his aunt and uncle, were too afraid to get vaccinated and died last month. Hours apart, COVID-19.
Struck us. Particularly when you know that there was a possible solution.
Trauma, fueling the race to change minds. Before it's too late. Megan Fitzgerald, NBC News, Washington.
Okay. So that was just one instance of medical racism, but I also want to talk about two other ones. So another example of medical racism was the experimentation of Henrietta Lacks. She was a woman back in 1951 that was diagnosed with a aggressive form of cervical cancer. And so a scientist, his name was Dr. Jones Howards. He was like a very renowned scientist and doctor in Johns Hopkins, took a sample of her tumor. And so after she died, he realized that her tumor kept growing. It didn't die. So he was like, what's going on with this? So he ended up sending her tumor all throughout the world to different scientists to do experiments on it. And through her tumor and through researches through her tumor, they were able to create many different cancer treatments. The creation of the polio vaccine is credited to her tumor, and also the creation of IVF, which these are all great things, right? But she was never credited or told that she was going to be basically experimented on, and her family was never told this. They never got any sort of compensation, you know, just another example of Black people being experimented on and not, you know, given credit. So then I have another one. This is more recent, but in 2019, a computer software algorithm that is supposed to help people seek healthcare for over 200 million Americans was found to be systematically discriminating against Black people. According to the research published in the Journal of Science, people who self-identified as Black were given lower risk scores by the computer than their white counterparts. So this led to them getting less referrals for healthcare. So that's pretty bad. So my PICO, so my population obviously is going to be Black, Brown, Indigenous people or Indigenous patients. My intervention was the studies on implicit bias in the acute or palliative care setting. My comparison was no implicit bias being reported. And then my outcome was the impact of implicit bias and racism on BIPOC patients and how it affects their overall care. So these are a lot of articles. I'm going to summarize them as best as I can. So for the first article, it was two studies that were based around whether Black people have thicker skin or have thicker skin or feel less pain than their white counterparts. So the first study took non-medical participants and asked them this question. It was a survey. And then the second study took medical students and asked them this same question. So the relevance of this study as it pertains to nursing is that it looks at racial biases in pain management, and the only way to improve pain management for all patients is to acknowledge these biases and to change them. So for Article 2, it looked at racial differences in the implementation of cancer pain management for a sample of people that were on hospice of different racial groups. And the relevance of this study as it pertains to nursing is that nurses and other providers should continuously engage in quality improvement to ensure that we are reducing these disparities in pain management, to increase effective pain management for all older adults with cancer, regardless of their race. For Article 3, this study looked at how Black patients with multiple myeloma reported their pain and how they feel about the pain management that they received while taking around-the-clock opioids. And so the relevance of this study was that it allowed these patients to express how they feel about their pain. Because, you know, like in the previous article, Article 1, it was talking about how Black people feel less pain or they don't feel pain as much as white people. So this article just gives a highlight to Black people to talk about, hey, I feel pain, this is what I'm going through. So I thought that that was important to include. So for Article 5, it just looks at the quality of pain management for people of for people with advanced diseases, for people of all racial groups. So it's white, Black, every racial group. So the relevance of this as it pertains to nursing is that there's a barrier to communication sometimes when it comes to, patients and doctors. So this just also highlighted the importance of providers educating and talking and listening to their patients, regardless of their race. So the results. So for the first article, it did find that there was racial bias when it came to Black patients versus white patients. The non-medical participants did report that they believe that Black people's blood coagulates more quickly than white people. And they also believed in Black people having thicker skin than white people. And then for study 2, which is, I think, a little bit more alarming because these are the medical students, they also reported the same thing. They felt like Black people felt pain less than white patients. And it just pretty much highlighted the medical racial bias between white and Black patients. And then for Article 2, this one was a little contradictory. The first part of the article, it was stating that there wasn't any meaningful differences between the pain management given to Black and white patients. But then later on, it stated that there was, they did have evidence to show that Black patients did not receive good opioid-induced constipation management versus their white counterparts. So it was like, it still proved the point that racial bias does exist in healthcare, but it was a little contradictory. So then for Article 3, like I stated previously, this one just basically talked about Black people talking about their pain experiences and how they feel like they're being treated when it comes to their pain management. So they reported having like the dislike for pills, fear of addiction, and having bothersome side effects for pain and medication. And then Article 4, education and trust were significant predictors of pain knowledge, whereas self-efficacy for pain and pain interference and pain severity were indicators of the experience of cancer pain. And then for Article 5, so this one had 18 different journals. So 10 of the 18 studies indicated no discernible variation in the amount of analgesics or pain meds given to individuals from various ethnic groups. But then it also pointed out racial disparities in pain assessment, and two studies discovered racial and ethnic stereotyping. So this one was also a little contradictory. So going on to the solution, I think that, the only way to solve something like racial bias and racism in medicine is education. It's the best way to, solve ignorance is educating. And especially for medical providers like nurses and doctors, I think that, stories like Henrietta Lacks should be taught, in lectures for nursing students and medical students, just to kind of give more context into how this affects, the patients that they're going to be taking care of. So I think education is a big part. Racial bias training led by people of color is really two of the biggest ways to help, try to eradicate the issue of racial bias and racism in healthcare. So that is it for my presentation. Thank you. Any questions?
I have a question.
Okay.
Was there anything in particular that led to the students stop there?
Maybe in Black, but
Yeah. Are you seeing this at all in your practice?
luckily I haven't seen that, but I know that is something like that I'm going to eventually see, and me going to be a nurse soon, I definitely want to be an advocate for not just, Black patients, all patients, but especially those underserved communities. That's one of the biggest reasons why I decided to go into healthcare, is because I know that there is a problem with providers listening to Black and brown patients. So, yeah. Thank you.
Okay, next up, we have Miss Jennifer Ponce.
Good morning. Thank you for being here. Like you said, my name is Jenny, and I'm going to be talking about cultural competency among hospital staff and if that actually improves patient outcome. So the purpose of my presentation is to review and to educate, help healthcare employees understand cultural awareness is necessary to provide better patient care and to understand that cultural competency is an important factor of the healthcare system. So I know that healthcare institutions could provide better translating services, but that is not happening for whatever reason. So always keep in mind when you're out there, if you end up working within healthcare, that not every interpreter is necessarily capable of mediating a conversation between you and your patient. So it is not the job of patient care tech, registration, family, or Google Translator to help you communicate with your patient. I think one thing that we need to keep in mind that the establishments that we work for should be able to provide us with the necessary tools to serve our patients, which at the end of the day, it's their clients. So I was reading a blog about cultural competency from Rebecca Smallwood, and the name of that blog is High Cost of Poor Cultural Competency in Healthcare. And she talks about how healthcare system has failed to keep pace with diverse cultural and linguistic preferences and the needs of patient, which has led to an increase in medical errors, prolonged lengths of stay, and avoidable hospitalizations. And I can think of many examples, if I'm honest with you. I've worked in healthcare for a bit now. And one quick story that comes to my head is I was called one night to go translate to another department in a big hospital. I don't know why I went, but I went, and there was a patient and he was just laughing. They were trying to check him in. He went through triage. He was already back there. And then I'm like, hey, what's going on? And he's like, I'm just looking for coffee. And I'm like, okay, he's just looking for coffee. And for some reason they had gone through triage. They were going to run labs. The doctor was there already trying to talk to him. And I'm like, he's just looking for coffee, guys. So one of many examples, if I'm honest with you. And so what's the problem? What's the big issue? So several studies have found that patients who can't speak English receive less than optimal health care and are at greater risk of many things like yearly screenings. They're not receiving yearly screenings. They're less likely to have regular patient primary care physicians. They're less likely to show up for follow-up appointments, less likely to follow up with appropriate care after hospitalization. They're less likely to be compliant with medical advice due to just being confused, or more likely to comorbidities due to lack of education. So I also have a few articles that I want to talk to you guys about really quick. And then the first one is the need for more pre-hospital research on language barriers. And that article explains the importance of communication and how language barriers impact EMS services in this case. So EMS providers rely on accurate and efficient communication to ensure safety and quick access to patients. They have to make decisions quick and it needs to go smooth. So language barriers make that process difficult to deal with, and an increase in communication errors, unnecessary invasive procedures, and also testing. So 22 studies conducted in different communities show that non-English speaking patients are more likely to rely on themselves to get to a hospital than have to call 911 because they fear they're going to lose time. They're not going to be able to talk to somebody. So they just drive themselves to the hospital. Second article, educating nursing students in cultural competency in emergencies. So the purpose of that study was to examine the effectiveness of online culturally informed interventions and if that was going to make a difference within the group of nursing students. So the overall intercultural sensitivity levels had increased tremendously at the end of the study. And as a result, it was observed that intercultural training is effective on students gaining skills towards different cultures. So I honestly think that teaching and exposing them to the problem actually before they get to those jobs can make a difference. And maybe by seeing what it can cause, it can help them advocate better for their patients. So also the next article, professional, okay, so that last art, yeah, I was trying to read that part up there, but it's okay. So that the purpose of that study was to explain how language barriers can affect the patient's ability to explain their symptoms. So the study investigated different differences amongst patients with limited English proficiency and their length of stay within a 30-day readmission rate associated with them receiving interpretation at the beginning of their admission and at the end. So the results were higher readmission rates and longer hospitalizations. If you think about them leaving and not understanding what they're being taught, it's not going to make a difference because, you know, we have seen, I mean, I'm sure you have gone home with a bunch of paperwork and you don't know what it means. Now imagine people that don't speak the language, or even if they do, they don't know what certain words mean. So it's clear the language barriers can affect those patients' ability to explain their symptoms and go home and try to, you know, feel better and not come back with the same issues again because they didn't know what to do when they went home. The next article, major disparities in COVID-19 for patients with non-English preferred language, even after accounting for race and social factors in the US in 2020. So that article was talking about the infection rates and mortality within communities of color and low-income communities. Hospitals are legally able or legally responsible actually to provide translating services. Does that always happen? No. So interactions and communications between non-English speaking patients and hospital staff usually rely on families or hog interpreters, as they call it. It's like, hey, you know, can you come help me? But then do you really know they're translating the right thing? Are you getting the right information? You know, you never know unless you're you know the language they're talking. So those patients are not receiving the right information or education, leaving them with poor understanding of their healthcare. During COVID, a lot of these patients were not receiving, or they knew they had COVID, but what does that mean? They didn't know, you know, they weren't being educated on what to do after that or the follow-up. Next article, the impacts of English language proficiency on healthcare access, use, and outcomes among immigrants. The purpose of that research was to provide information on healthcare providers and to demonstrate that limited language proficiency often delays access to available healthcare services and interferes with a relationship between the client and the provider. So that study emphasized the need for provide language assistance during medical consultations and the importance of establishing the guidelines for recruitment, training, and effective engagement of language interpreters during medical visits. So professional interpreters raise the utility of clinical care compared to a hawk interpreter. Like I said, you don't know what that interpreter is telling you. You know, so it just be careful with that. If you're out there and you find yourself in that situation, just to make sure the patient's really understanding what you're saying, because at the end of the day, you're the one educating and, you know, trying to advocate for them. So solutions. What can we do? I think that on-site interpreters should be available for the most commonly spoken foreign languages 24/7. And documents should be printed out in their languages, labs, results, consents, and simple languages that they're able to understand. Healthcare websites should also be, I think it should be posted in different languages so they can, navigate through that. And additional time should be scheduled for visits when language services are needed. That's more of an outpatient thing, but I'm sure it'll help them also. And healthcare providers need more education and training in using various methods of interpretation if it gets to that point. I honestly think that hospitals are well aware of the communities that they serve. So if it goes through your mind, well, what if there's, different languages or what can they do? The hospitals know who their communities are, who they serve. So they should know who they need to be inside and who can they have on the phone in case, they show up. So that's that. And then lastly, try to put yourself in their shoes or think about how you would want your loved one to be treated in a situation like that. My references.
So the example that you gave when you were asked the copy, certified.
Yeah.
Copy, have you gotten certified as a translator or were you just kind of asked?
I was just asked to do it and I chose not to get certified because there's a whole thing about that too, where there's like an 8-week to 12-week course that you have to take and you don't get any compensation for it. So I don't, I've done it for so many years and I don't think I'm gonna get pulled either way. And then I don't get any compensation for it. So I haven't done it. Yeah. Thank you.
Video online, and I was kind of wanting to know if it'll work. But I kind of put it towards the end of
But it's worse. Okay. So
Yeah,
it's up here. Okay, so where's your link out?
it is right there.
Okay.
I was wondering if it would play, if you click on it, if it'll play. And like, right, if you click in the middle there. It worked on mine. I wasn't sure if it would work on here, but if not,
Well, let's just see if we can do. There we go. So whenever you come to this, you're gonna have to
sharing.
stop sharing, then go to that. So
Well,
I
how
can,
do I-
okay, so I'll share the screen right now to, this is your PowerPoint.
Mhm.
So now it's screen sharing.
Okay,
And then whenever you get to this video, you're gonna stop share,
okay,
play the video, and then go back down to Zoom
okay.
and you share. If you have any questions, I can come.
Okay.
It's now that I can start this for you.
Thank you.
So this is Vanessa Marrero. She's gonna be talking about music therapy.
Okay.
Hi, everyone. My name is Vanessa and I'm a senior in our nursing program. And today I'm going to be talking about music therapy and healthcare. So before I actually start to get into it, I think there's a saying that music is good for the soul. And I tend to agree because music has a unique way of building connections. And I think it's truly a positive form of expression that can be a part of the healing process. Okay, so what is music therapy? Music therapy is a form of supportive therapy that promotes relaxation and companionship. It serves to reduce feelings of fear, stress, and anxiety while also providing distraction. And how does it relate to nursing? If indicated, the nurse can request a consult with a licensed music therapist and then can further coordinate with them how to proceed moving forward with the patient. I think it's gradually becoming a non-pharmacologic method to relieving pain, and it can be especially healing for patients that suffer from from symptoms of a chronic condition. So that's kind of where a lot of my focus is going to come from. Which brings me to my PICO question. What is the influence of live music therapy on pain management? So my population are patients that suffer from recurrent chronic pain across all age groups. Intervention, live music to distract from pain, comparison, other non-pharmacologic interventions, and of course, our desired outcome, the patient will express relief from pain. So my first article highlights 8 studies performed on older adult patients. Of those 8, 5 were randomized control trials, while the other 3 were quasi-experimental trials. And so their interventions that they used, depending on which group the sample was put in, was live music, recorded music, and active music, which I'll explain more in a second. 6 of the studies included patients that have cancer-related pain, osteoarthritis, and pain associated with dementia. So the group that participated in active music were Alzheimer's patients in the mild stage. And what they would do was have them participate in choir. So they would sing for a certain amount of time during the session. And I thought that was interesting because having them sing together brings that element of interaction. And overall, the study, 5 of the studies concluded significantly positive outcomes for reducing pain and its common comorbidities in older adults. And the remaining 3 reported no significant difference. However, there were decreasing trends in pain scores, and the group of palliative care patients that were delivered live music displayed a decrease in pain, secondary symptoms, and less opioid use. There was something about this first article I also thought was interesting. There was another group that was assigned music based on the type of music they would have listened to when they were in their 20s. And I thought that was interesting because this age group for the study that they used was age 65 to 87. And so if they had given them music that they might have listened to when they were in their 20s, it probably would have given them that feeling, taken them back to that feeling of when they were young. My second article was a randomized control trial with 80 infants. The study compared preterm infants who received music therapy during kangaroo care with preterm infants that did not receive physical contact. The study trends in vital signs. The music therapist would sing melodies or play an instrument called the sansula. The group of infants with physical contact during music therapy had a decreased heart rate, decreased respiratory rate, and an increased oxygen saturation level compared to baseline values. And the live music therapy may provide benefits, but overall, this study concluded that further investigation is needed. My third article was a pilot study on the influence of live music on patients' vital signs. And these were preoperative patients, and they were studying the effects of live heart music versus recorded heart music on pre-op patients to see the effects of reducing feelings of fear and stress. And the overall findings were that the live heart music was much more effective at reducing heart rate and systolic blood pressure than the recorded heart because the acoustics of the heart is much more powerful in person. And I believe in this particular study, there was a survey given to the nurses. And I think that element is also important because the nurses collaborating with music therapists and other members of the care team is also very important. My fourth article was done on a pediatric intensive care unit on patients getting mechanical ventilation and sedation. The participants were randomly allocated to receive live music interaction with their standard care or recorded music with their standard care. Their intervention was the use of guitar and vocals tailored to the patient's needs. Most of the patients in the live music group maintained a heart rate below baseline for 60 minutes after the intervention, possibly indicating a relaxation effect extending longer than the actual session. And my last article also focuses on hospitalized children, because I think from a child's perspective, being in the hospital for a long time raises the fear, concern, anxious, worry. So in this particular study, they compared kids that got recorded music versus storytelling. So it was a little bit different than the other studies. And The results concluded that both interventions equally had significant positive impact in managing sleep disturbance. Okay, so my summary. Many of the studies conducted on the use of music therapy found a significant decrease in pain trends and improved vital signs. Music therapy provides an outlet for positive expression and individuality. The use of live music allows for care tailored to the patient's physiological needs. Most common finding amongst the studies is the need for further research and investigation despite positive results. And its impact on nursing care, while it's not the most utilized method of treatment, it has the potential to be of more use moving forward in healthcare. It could be something that some of us in here who are planning to be nurses or in healthcare, could be something that we could advocate for. And before I wrap up here, I included a video of an Alzheimer's patient. She has headphones on and they had played her Swan Lake. And the reason that I came across it recently and I wanted to include it because I think it was a good visual representation of kind of what I've been talking about. So I'm gonna try and play it, see if hopefully it'll play. Are you guys able to hear? Didn't want to take up all the time. I was wanting to just show some of that. But yeah, so this patient has Alzheimer's, and I believe this took place a couple of years ago. And the articles that I read about this were all in Spanish, and I think it might have taken place somewhere in Spain. And she was, I believe, a ballerina when she was younger. So when they played the music for her, she just, as you guys kind of saw, she moved her arms and she just transformed, just, you know, just out of nowhere, just remembering the way she used to dance. And I just thought it was so beautiful that I wanted to share. I'm sorry. Can I? Yeah, and references. That's it. Thank you. If you have questions, please feel free to ask.
So, with no, I think that music is helpful with healing and mind, body, all of that. I wonder why we don't use music in the hospital. But I'm curious why you chose to look at live versus recorded music. What was your thought process?
I wanted to see if there were studies out there about if there were differences between the recorded music versus having someone there really kind of interacting with them, and the patient can see up close. So I thought, that's kind of where that came from. I wanted to see if there was if there would be a difference, if it would be better or about the same for them. But I think overall, just that interaction, I think, is very therapeutic. Here and there, but actually I'm surprised at what I found, because my focus was chronic pain, because we see that a lot in the hospital, especially during clinicals, patients that are there all the time, for their pain and, you're not wanting to always just give pain medicine because it just, there's other ways. Thank you.
Do I click out or?
Yeah, I should explain. I don't have. I should have copied that. And we can come with us there. Yes, that's my first thing that's going to be before. I'm gonna go there, but we're gonna take that. Yeah, but it's a I did. Because, and this is not right. I had to learn. Yeah. For a little while. Yeah. We, changed the program, we're going off on it, loved it. It kind of made me feel. I mean, it is my nothing, and it's not, it's fun to overleave. Music maker. Like playing it. Yeah. Love that. But like, the first only wanted out there. Yeah. Right. Pretty much out of the state, and I from all like stuff, the trumpet. I don't know, that's too big. Yeah. But like, with the trombone, it's the right time. It's the right time. But then, I can see that. We haven't done, we don't do that. It's so good, it's smaller. Yeah. Yeah. Very, very, yeah, tell us how you end up.
I'm gonna wait until Amy comes, she's the next year in the system.
No,
Sorry, sorry.
Oh, yeah, I think
Pay for your session.
oh, no, they really want to, they learn from more, so. Yeah. It does. You can call it, but I don't know. And I was like, that's the way to get them. Not our masters in the winter.
Yeah.
My grandmother, or we supposed to try it for, you.
Yeah.
Yeah. Because they're younger. Another vacation of it right now, I'm like, I don't know, I would be very. We didn't trust it to see the inside. Yeah. I mean, how do you- that way, it's direct. We have a we have a player, and what's China's part of the power based on. Actually, whenever she was younger, we get started. Yeah. They don't, yeah. We don't pay. I feel like my other neighbor, I'm like, the fair, so the dog is like, behind the center, and I don't know how you translate. Oh, yeah. Not enough to translate for the two of you now. still getting so very, and then that's one of the things I'm sitting here and rolling, and then you got to feel like I'm a little old person, they sitting in the shit like. How long is not? Translate in English. Yeah. We have someone that something goes wrong. Yeah, that's. We didn't value. Girl, you're not. Nowhere. Thanks, that's why I said, that's why I said, your area. Where I'm from. Yeah. Yeah, for me, no, but that's why I said no. I love them, nowhere near. Oh, sorry. So it was easier for you to get on there then. Yeah, but let's see. So freaking hard. Or you know something. Stay on your water. They want you to say multiple. Yeah. They're all good. Sure, they would be interested in this, but I guess I was wrong. We do that for babies when they're in nursery. Oh. So you always have to take into consideration, like especially kids in the children's hospital. Oh, a lot of them are left alone. So like it's music everywhere, either the TV or the whatever toys. Because a lot of them. They just kind of need that comfort. A lot of them don't have parents or anybody at the bedside, so. And I'm just talking about it would be okay because I grew up playing music and it definitely, I'm definitely not a prodigy by any means, but this was always fun for me. Because I wasn't an athlete or anything, but I loved playing stress. That's what we do. Listen to music. That's my source of music. I'm glad you guys could watch. Did you present already? You went for, oh my God. I was stressed the whole ride from here. No, I didn't stress with that, but it's a dang predicament. I really. Oh my God, I was so stressed. I could not believe that on the first try. I was worried, it was long. I wasn't sure if I was going to left, it was 3 of us when I left. I was surprised. And then I was like, hello, because when I finished, it was 3 of us left. I was like, I'm not speeding through that. And I'm like, got up within an hour and a half. I'm glad I took the break though. I wasn't sure if I was going, I was like, maybe I can just power through for the house. No, I gotta take a break. I did a break. I would have been like jacked up. Yeah. I would have been you guys didn't take a break? No. I tapped. I was like, I'm gonna hold his feet. I'm gonna hold his feet. Didn't you see?
So this, I'm gonna kick you out. for a second. This folder's already set up, so we're in Daniel 3:11, and then it just goes by the times. Okay. So you open up the 11:20 session, and I think it's pretty much in order.
So when I come up, I just come up and kind of.
Yep, you can double click and open up their PowerPoint. So the Zoom is already running. Don't have to do anything there. Once you open up their PowerPoint, you'll need to do a share screen. Okay, you know how to do that. I mean, they don't know how to do it because they don't present on Zoom, but yeah, so you'll just have to share a screen to their PowerPoint and get that set up. And then that's it. In my first session, the MC had no idea how to do any of this. In the second session, he did. So, that either you or the MC can help out with that. And then once you get to the next session, just go back to Daniel 3:11 and open up the 12:30 session. So that's it. Other than that, it's pretty easy. You're welcome.
Yeah, I know.
I'm trauma in. Yeah, north side filled up so fast, and I was just like, it is what it is. No. Oh, I know. And I waited late to do any of my, so that was my fault. Yeah, I waited. I didn't either. I see, I was late January. That was when I did Trump, I thought they were gonna do that too, but no, they just kind of let me speak and then they spoke. She thought they called me the next day before 9 o'clock. So I was like, whatever. Yeah, I just said,
No, I ended up getting a TV spot where in Rasmussen.
gotcha.
Yeah, because I got an offer for L&D, but in St. Mary's, and it's like an hour and 15 from me.
It's St. Mary's.
In Tappan.
I'm not talking about that.
You are from there? It's not.
Yeah, that's all they offer. What else should we?
So I'm like, an hour, I'm like, it is a place I wanna be at, but an hour and 15 and you know, it doesn't, I'm like, I wanna be there, but it's not.
By the time I finish with the hours, the 50 and my space station, I'll be right at 47.
Hey,
And
where's it true?
Northeast Georgia. Gainesville.
In Kings? Okay.
They're not playing at all.
But I did love their elementary school when we got.
Their floors in general, oh my.
People, no people in their right mind like that, are they? You know?
Not many take it out.
Without your bracket.
That's come with their choice.
Oh, yeah. Oh, no, Juliana.
When I saw you, we hated go, she was with me, hated going,
She was telling me, she was like, this is not.
hated it. When I tell you, I said, like, all my practical skills were, I'm not practical, but just my skills were at the end of the semester. When I tell you, it just was dreadful.
Yeah.
What time? Yeah, she
Or
was.
11:20. I don't know.
It's 11:20. That's what I y'all. Wait, I'm looking at my. Why did I start off 9 o'clock, 10 o'clock, 11 o'clock? I said that. Yes. No, you don't. Yeah, they're down to
So which floor are you?
Oh.
Are you nice or day? Are you doing nice?
I want night. I want
Yeah, I
night.
think we're almost was our
I
note.
want night.
Right?
I prefer at night.
Yeah, I was nervous about it, but I'm like, I feel like it'll be good.
I don't know, they stay in Brownston and you know, they got.
Oh, they did, I asked.
My coworker,
Yeah.
is like, she wouldn't, yeah, she was like.
But yeah, because I asked them, I wanted to know about the overturned vision and all that, and then they told me that, yeah, it was high, but they changed management this year, it's hoping for better money. So I'm like, okay, so we're going somewhere, at least
Yeah.
making changes, you know what the issue is, so. Yes.
But my coworker was like, poor.
It's like, so I'm like hoping it's better.
Oh, she said she did it. Now, mine, ER nurse, that's the same nurse. But she said, with, I think, I don't know if she went around, but she says. I would think, y'all. The rest of it.
Buses.
I don't know. She said, how would it be, what they pay her? Whoa, outside of what she makes. What else?
We love all. And you know what, that, the manager told me straight up, he's like, every time we like. Yeah, if we don't get raises, our raises. So, and but then the recruiter was like, you know, we're trying to screen. No, they ain't, they tried. They ain't saying it. They don't pay attention. So I was like, okay, I tried, I'm like, am I think last spring. Like, you know, yeah, and they made that like this, you know, what I mean, yeah. So I did. Are you moving closer or? I'll commute. I just, that's what I just want. Better. Yeah. That's kind of what. I ain't gonna stress over it. And I tried to ask about a drove for 2 years. Yeah. It ain't. You're gonna be okay. Yeah, yeah. Yep. Germany. Oh, I'm not.
You're not. Okay.
Yeah. Great.
Good. Good.
Jennifer, right? Do you have any videos or anything you're showing?
Oh, hold on. Which is like, yeah, we know. Yeah, I want it at 9. And then they say you got 3 minutes. Yes. Unless they're somewhere else, like other business. Like, are you gonna wear that? Actually. What is yeah. I think she's still.
I think it's different. I think I like that. I'm worried about figuring out how to relate it to the air. That was part of it. Everything to make things smooth. Yeah, so it's. That's what's waiting on the next one, right? And then the one.
Yeah. Yeah. Okay. Can I start now? Hello, everyone. My name is Jennifer, and today I'm going to be answering the question of, are prima gravida mothers more susceptible to postpartum depression compared to multi-gravida mothers? And just so everyone's on the same page, prima gravida means first-time mothers, and multi-gravida means mothers that have had multiple births and have more experience. So before we get started, I'm just going to share some facts with you because postpartum depression isn't something that is talked about often, and I want to share that it's more common than you think. So 1 in 7 women experience postpartum depression. About 1 in 5 women were not asked about depression during a prenatal visit. And this is pretty important to consider, especially because one of the biggest risk factors for postpartum depression is having a history of depression and anxiety disorders. So if a woman does have a history of this, it's really important to put a treatment plan in place to prevent this from happening. Over half of women do not get treated for postpartum depression, and because these women do not get treated at all, suicide accounts for 20% of postpartum deaths. Okay, so I'm going to share some causes so you can get a better understanding of postpartum depression. So there's not a single cause for postpartum depression. So it's basically a combination of several different things that can collectively cause this. And like I said, like I've mentioned previously, one of the biggest risk factors is having a history of depression and anxiety. So if a woman is predisposed of depression and anxiety, then it's pretty important to make sure that they get the resources and help that they need. to prevent this. Also, physical changes can cause this. So when a woman gets pregnant, there's two hormones in the body called estrogen and progesterone that increase in the body to maintain a healthy pregnancy. And after the baby delivers, these hormones drop significantly, causing mood changes, and this can in turn lead to postpartum depression. Your emotional state also has a lot to do with this as well. So when a mom is adapting into the maternal role, she most often loses sleep because, most likely the baby wakes up in the middle of the night to eat. And if a person doesn't get at least 8 hours of restful sleep, then this can cause, mood changes and then lead to depression. Body image insecurities as well. So, of course, after a woman delivers a baby, her physical body does not go back to pre-pregnancy body, and this can be very difficult to deal with and adjust to. And just overall losing a sense of self while going through the process of adapting into the maternal role. Okay, so how is postpartum depression identified? So the best time to screen for postpartum is 2 weeks after delivery. And this is mainly to distinguish between baby blues, which is similar to postpartum depression, but it doesn't last more than 2 weeks. And if it does last more than 2 weeks, then that's when we get into postpartum depression. And it can actually occur up to a year after delivery. So it's really important to monitor any changes in these moms in order to provide a treatment for it. Okay, so some of the symptoms that may present include being sad or anxious most of the day, not being able to sleep at night, or being excessively tired because you didn't get enough rest, feeling agitated, feeling worthless or guilty, having a loss of energy or feeling excessively tired throughout the day, having suicidal thoughts or even attempting to harm yourself or the baby is one of the biggest symptoms, and this needs prompt treatment. Impaired concentration or being too indecisive, a change in weight or appetite, especially if it's a decreased change in weight of 5% or more over 1 month. Okay, so there is a scale called the Edinburgh Postnatal Depression Scale, and this is a 10-item questionnaire. So the scores range from 0 to 30, and of course 0 to 6 is none to minimal depression, 7 to 13 is mild depression, 14 to 19 is moderate depression, and then we go into our severe depression, which is 19 to 30, and the highest score that you can score on the scale is 30. And this is what a sample sheet looks like. So like I said, it's a 10 questionnaire, 10 questions on this, and it's based on the past 7 days. And it's really important to pay close attention to item question number 10 because it directly asks the mother if they have a thought of harming themselves. And of course, if the answer is hardly ever, sometimes, or yes, quite often, then this needs prompt treatment in order to prevent any harm from themselves and from the baby. Okay, so now that you have a better understanding of what postpartum depression is, I'm going to talk about 2 different studies in order to determine who's more susceptible, whether that is first-time moms or experienced moms. So for this first study, there was 3,769 women that were examined at 13 different hospitals. And the tested method for this was the Edinburgh Postnatal Depression Scale. And the category or the groups that were tested for this study included younger and older first-time moms, as well as younger and older experienced moms. So these moms were followed and tested at 1, 2, 4, and 6 months after delivery. And so Based on the results of this study, the average Edinburgh postnatal depression scale scores notably decreased from 1 to 2 months postpartum in all groups. And the portion of women with scores higher than 9 significantly decreased during the same month for first-time mothers, but not for experienced moms. And also, first-time moms had significantly higher scores during the hospital stay and 1 month postpartum. So with that being said, for this study, it's important to pay close attention to that first month, especially for first-time moms that are adjusting to motherhood. Okay, so for my second study, there were 2,854 women that were examined in a 6-month time span. And the testing methods were a little different. So for this one, it included, of course, the Edinburgh postnatal depression scale, also the postnatal accumulated fatigue scale, the postpartum maternal confidence scale, and the postpartum maternal satisfaction scale. And the groups for this study were the same as the first study. So we have our younger and older first-time moms, as well as younger and older experienced moms. Okay, so the results for the second study concluded that both younger and older first-time moms were more severely tired, and they had a much higher risk of postpartum depression compared to multi-gravida mothers during the first month after delivery. And older first-time moms had significantly lower scores on maternal confidence and maternal satisfaction than the other 3 groups at 1 month after delivery. So we can kind of see a trend that mothers are at more risk for developing postpartum depression during the first month after delivery. Okay, so based on both of the results, the first month after delivery is a sensitive period where mothers are at more risk for depressive symptoms, especially first-time moms. So postpartum nursing should focus on promoting enough restful sleep, which I know that's easier said than done, but it's important in order to function properly. Also providing emotional support, especially for first-time moms that are adapting into motherhood and don't know what to expect yet. And lastly, fostering the process of maternal role adaptation in mothers for them to be more confident. Okay, any questions? Yes.
Is there any medication that a pregnant mother can take?
Yeah, so there's so if a mom does have depression, there's certain antidepressants that they can take. I know that the most common safe ones are Celexa, Lexapro, and Zoloft. So there is certain medications out there. Any other questions? Yes.
Where is this used most common from what you researched? Where are women most commonly diagnosed with postpartum depression? Because a lot of women don't get a lot of postpartum care. They get discharged from hospital.
So usually this scale actually needs to be given in the hospital during their stay. I know in one of my clinicals in Mother Baby, one of the nurses gave the scale to the mom and was assessing the mother's depression because this can, especially because of those drop in hormones, it's especially important to monitor it like during the hospital stay. And it can also, like I said, it can occur up to years. So it's also important during like the post visits after delivery for the providers to be also assessing this as well. Is that it?
this time, sorry, I just realized that.
This, I don't have volume. I don't have,
If it's speaking, no.
no. Well, yeah, that too. No, I accidentally left my voice on one of the slides and I don't want it to like.
No, I
Okay.
don't think so, but I can show you what to do real fast. Is this you right here?
Yeah.
Okay. You care if I just go and delete it?
It's that one.
Can I delete it?
Yeah.
There, so you don't have to worry about it.
Okay.
But there, I don't think it would have popped up either way.
Okay.
Jessica Velez, right?
Yes.
All right, next we have Jessica Velez, and she is doing the effects of kangaroo care on parental infant bonding. I want to say prenatal or
Yeah, I can't
parental.
say that word either. Hello, I'm Jessica Velez, and I'm doing my presentation based on the effects of kangaroo care on parental infant bonding. So my PICO question was, among neonate care, does receiving kangaroo care compared to those not receiving it improves both emotional closeness and better health between infant and parent? So the P was neonates, I is the kangaroo care, the C is those not receiving the kangaroo care, and the O is improves both emotional closeness and better health between the infant and the parent. So what exactly is kangaroo care? It's a care system for the baby. It's good for neonates, especially for the premature babies. You use the chest of the mother or the father or anyone that wants to collaborate instead of the incubator. So the history of kangaroo care, it first was discovered in Colombia, which is a country in South America, in the year of 1983. And there's approximately 84% of neonatal ICU that are doing kangaroo care here in the United States. So why and how? So it's skin to skin, and you put the baby chest to chest with the parent. You should try not to have the baby completely flat on your chest. So you try to cover from the belly button to the sternum of the baby completely on your chest. So it's recommended that you rather stay not laying flat on the bed, but maybe in a recliner or something like that. So my first article was, this kangaroo mother care alters chromogranin A and perfusion index in preterm babies. So chromogranin A is correlated to having lower survival rates and also with liver cancer. And the purpose of this study was to see if kangaroo care can reduce the CGA levels and if the PI in preterms is increased in infants. So this was a experimental study in neonates, and its salivary chromogranin A is elevated upon exposure to stress, where perfusion index is associated with hemodynamics and peripheral perfusion. They investigated the effects of skin-to-skin contact on CGA and the PI in the preterm infants. And the sample consisted of 12 infants that were enrolled in the study. Factors associated with the baseline SCGA were analyzed, and baseline SCGA and the level after skin-to-skin contact were compared. Secreted IgA in the saliva was compared as the control, and the PI before, throughout, and after skin-to-skin contact were also compared. So the results of this study was that, according to the article, it was concluded that babies who were breastfed showed a decrease in CGA levels versus babies who were fed formula, and babies who were breastfed and had skin-to-skin contact had a significant lower CGA level. And skin-to-skin contact did not affect IgA in saliva, and PI was significantly elevated during the skin-to-skin contact. So my second article was kangaroo mother care and the neonatal outcomes. So the purpose of this study was conduct a systemic review and a meta-analysis estimating the association between kangaroo mother care and neonatal outcomes. So this was a descriptive research, and kangaroo mother care would decrease risk for neonatal sepsis, hypothermia, hypoglycemia, and hospital readmission, and increase exclusive breastfeeding. So there was 1,035 studies that were screened, and out of those, 124 met the inclusion criteria. Among low birth weight newborns, kangaroo mother care compared to conventional care was associated with 36% of lower mortality. The results of this was that newborns receiving kangaroo mother care had lower mean respiratory rate and pain measures, and oxygen saturation, temperature, and head circumference growth. My third article was, what are the effects of the kangaroo mother care in the NICU? So the purpose of this study was to analyze the randomized control trial that explored the effect of kangaroo mother care on the psychological stress parameters of the premature infants. So this was a meta-analysis study, and they used the PRISMA model to conduct data extraction. They performed a narrative synthesis of all these studies and a meta-analysis when data were available from the multiple studies that compared the same psychological parameters with the kangaroo method as an intervention, and controls used the same outcome measures. So there was 2 independent researchers perform a systemic review, which included data from randomized control trials measuring the effects of kangaroo care compared to standard incubator care on psychological stress, outcomes defined as oxygen saturation, body temperature, heart rate, and respiratory rate. And 12 studies were eligible for the inclusion in this meta-analysis. According to the statistical analysis, the mean respiratory rate of the preterm infants receiving kangaroo mother care was lower than that of the infants receiving standard incubator care. Infants who received kangaroo mother care had a higher mean heart rate, oxygen saturation, temperature, although these results were not statistically significant. My 4th article was the effect of kangaroo care on the maternal attachment in preterm infants. So the purpose of the study was to determine the effects of kangaroo care on maternal attachments in preterm infants and the mothers in Turkey. And this was a quasi-experimental study. This was conducted in a quasi-experimental research design between October 2015 and February 2016 in the neonatal intensive care units of 2 hospitals located in the east and west of Turkey. And data was collected by the research using the inductory form and the maternal attachment inventory. Data analysis was performed with statistical package of social sciences. So 18 software packages, and the data were analyzed using percentile distributions, mean, standard deviation, t-test, and chi-square tests. Officially, permissions and ethical approval were obtained to conduct the study. So the sample was the study population consisted of preterm infants hospitalized in the NICU, and at the same time, the research met the study group selection criteria. The study population was divided in 2 groups as an experimental and control group. Kangaroo care was provided to the infants in the experimental group by their mothers, and no intervention was applied to the infants in the control group other than the routine practices. So the results of the study was determined that the experimental and control group included in the study was similar in terms of the characteristics of the baby and the mother. And the study, the mean maternal attachment scale of the group in which the kangaroo was provided was higher than the control group, was a statistically significant difference between the groups. My last article was what are the effects of the fathers during kangaroo care? So the purpose of the study is to show that kangaroo care doesn't only show positive outcomes for the mother and infant, but the father as well. This was an experimental study, and the intervention consisted of continuous skin-to-skin contact for 4 consecutive days and nights in the family room. And data was collected every day during the intervention and again at the time of discharge of the hospital. The outcome measures compromise activity tracker, validated self-related questionnaires concerning sleep, mood, and bonding, observed scoring of parental sensitivity and emotional availability and salivary cortisol. Data was analyzed with precise repeated measures, and the Mann-Whitney test was used to compare groups. Analysis of the variance was used to adjust for different hospitals and parents' gender. So the sample was a randomized intervention study with 2 arms, intervention versus standard care. And data was collected from 50 families. The eligible families were randomly allocated to intervention, and standard care were transferred from the intensive room to the family room and the NICU. So the results of this study was showed that kangaroo mother care can be used to improve the maternal attachments in both mothers and fathers with infants. It improves breastfeeding and weight gain status in infants as well. And my conclusion on the presentation was that hospitalization of an infant can be extremely stressful for caretakers, and one of the worst stressors and the changes in parental role that course. The finding of the study suggests that kangaroo boosts caregiver confidence and self-esteem is linked to a rise in caregiver initiative and actively taking part in the baby's care. This suggests the possibility of a change in neonatal care in which the caregiver would take a role of the infant's primary caretaker in NICU setting. The change might be adventurous to both the caregiver and the infant. Being actively involved in the baby's care empowers the caregiver and strengthens the link between the caregiver and the infant. And the enhanced bonding has impactful psychological benefits for the caregiver as they cultivate their sense of attachment and closeness with their new baby. And these are my references. Questions?
I was asking.
Do you want me to save this? Sorry, it just popped save or no? Okay. Oh, okay.
I was gonna ask about mother versus other people, but then your fifth article talked about that a little bit.
Mhm.
But did you see any articles, or did any of the articles discuss like if the baby is given kangaroo care from someone they're not related to? They were like family member or like a nurse if the family is not.
Mhm.
Did anything
I think anyone could actually do it because I did look at a video about like, you know, some kids are adopted as soon as they're born and it's not the real mother, obviously. And the kid, the baby still has the same effects. So I don't
Yeah,
think.
so a lot of the results were about like attachment.
Mm-hmm. Yes, ma'am.
The enzyme levels. That
Yeah.
also were affected even when it wasn't the mother.
Yes. Mm-hmm.
The top one?
All right. Next, we have Catherine Malcolm, and she is going to present in healthy pregnancies, does artificial reproductive technology versus natural conception influence the incidence of birth defects?
Okay, my name's Reese and my presentation is doing a study like on the effects of using artificial reproductive technologies to conceive and if they cause an increased risk of birth defects.
Good afternoon. My name is Reese and I did.
Okay, anyway.
Do you have any others that have that recording on?
Oh, that was it. Sorry.
That's the only one.
I forgot.
Okay.
Since the early 80s, assisted reproductive technologies have become increasingly popular among women and families all over the world. In 2017 alone, there were 200 ART cycles reported in America, which resulted in over 78,000 live births. With the increase of the use of these technologies, we have also seen an increase in the incidence of birth defects. So again, I'm going to start by going over a few of the most commonly used methods, such as in vitro. This is probably the one that you've heard about the most. This technique begins with giving the patient fertility medications to kind of get their body to go into ovulation if that's the issue that they're having. Then they will go through and have an egg retrieval by the physician. He'll go in and he'll take some of the healthiest eggs, and from there, he's going to collect a sperm sample from either the donor or the father, and he will mix them together in a little petri dish, and then they'll see if they can get an embryo to grow. So then the viable embryos will be transferred into the uterus within 3 to 5 days from the retrieval. And usually they are going to do multiple just to make sure that, well, hopefully that one of them will stick. A lot of the times that's how these women end up with like 5 babies. The next one is intrauterine insemination. And this is more simple. It's like where the sperm is directly placed inside of the uterus. So they wait until the woman goes into ovulation and then they go up in there and they directly place it. And this just kind of gives the sperm a head start. And so hopefully they don't have to work as hard to get to the eggs because they're already kind of there. And then ovulation induction. This uses medications that stimulate the body in ovulation. This is commonly used in women that have irregular menstrual cycles or unexplained fertility, and this is often like the starting point for where they go. And usually it's either orally or it's through injections. And this will they'll take a cycle and then they'll see how it goes. And this technique can be used alone or coupled with other techniques such as in vitro or intrauterine insemination. Okay, now we're going to go into my articles. So my first article I reviewed focused on research in the association of births conceived with assisted reproductive technologies and their correlation with the increased risk of birth defects. This study included over 11 million births that took place in the United States between 2011 and 2013. The research found that the risk of birth defects increased from 25 in 10,000 spontaneous pregnancies to 77 in 10,000 pregnancies that were conceived using these art therapies. And the birth defects that were most commonly occurring were cyanotic heart defects, cleft palate, and hypospadias. My second article also focused on examining the correlation of art therapies and their increased risk of birth defects. This study included over 100,000 children conceived using the art therapies, over 20,000 naturally conceived art siblings, and over 1 million naturally conceived children. And this study included data from Texas, New York, North Carolina, and Massachusetts, given this a very diverse and large population. The final results concluded that the use of art therapies does increase the risk of birth defects, such as cardiovascular defects and singleton births, and chromosomal defects, such as trisomy 21 in twin births. So for my third article, I focused on the correlation of Beckwith-Wiedemann syndrome and the use of in vitro fertilization. Beckwith-Wiedemann syndrome is a congenital growth disorder that causes abnormalities such as enlarged tongue, organ and body overgrowth, abdominal abnormalities, and hyperinsulinism that results in severe hypoglycemia. In this study, 301 fetuses were tested, resulting in 40 positive samples with Beckwith-Wiedemann syndrome, and 16 out of the 40 samples were conceived using in vitro fertilization. They also found that there was an increased incidence in malacil, which is a GI disorder where one or more of the organs are born in a little pouch outside of the baby's body. And this is easily fixed by having surgery usually, and they have a good prognosis when treated effectively. And this article concluded that there is a 20-fold overrepresentation of babies born with Beckwith-Wiedemann syndrome and of malacil that were conceived using art therapies. The fourth study I found focused on the use of art therapies and the increased risk of craniostenosis. So craniostenosis is when the sutures of the skull are prematurely fused together at birth, and this can cause issues with brain development and can cause the skull to become severely deformed if not treated. If you know that the most rapid development is the first year of life, so if their brain doesn't have anywhere to like grow because the sutures are already kind of fused together, then that could cause a really bad problem. This was a smaller study in Iran, so there were only about 200 infants included, and out of the 200 patients, 43% were plagiocephalic, 39 were trigocephalic, 8.5 were scaphocephalic, and 1.5% were mixed. The study said that there was a 4% prevalence of IVF used among craniostenosis patients, suggesting that there's a possible link, but since they had such a limited study that they don't have clear evidence to support it. And for my final article, I reviewed was a study about the use of oocyte activation and the increased risk for birth defects. This was a study out of China, and unfortunately, only 16 out of the 76 records they pulled were able to be used, making the study group extremely limited. Since there was not much research, they concluded that based on the data they had, that there was no significant prevalence in major birth defects. So to synthesize my data, most of the literature did prove that there is an increase in rates of birth defects when artificial reproductive technology is used. in conclusion, there is an increase in the incidence of birth defects when these art therapies are used, but continued research is needed to gain better knowledge and further investigate this so we can have a better understanding. Anybody have any questions?
Interesting topic. What made you decide to go with this?
In my dad's family, his cousin conceived both of her kids using IVF, and they both were born with birth defects.
Were there any, like suggestions or thoughts from the articles that you saw about what to do? Because you know, some people are pregnant otherwise, so. What's the solution?
I think really it's up to that person whether they want to take that risk or not. Like, it's not telling you that that's going to happen, but it is a risk. But it's a risk with a naturally conceived pregnancy too, that you're going to come out with a birth defect. But it just really basically, they just said that this is a risk and a lot of people are going to take it anyway. But it's just informing people about what could possibly happen. Thank you.
I introduced you all to. All right.
Somebody's trying to call your name over there. Somebody's calling your name.
What?
Said she was calling you.
Oh.
I think she was trying to wish you good luck. All right, oh, wait, that's the PDF. There we go. That's what I want. All right, next we have Tori Roper, presenting birth outcomes of maternal nicotine and e-cigarette consumption.
So I'm Tori, and I chose to do birth outcomes of maternal nicotine and e-cigarette consumption during pregnancy. How do you go to the next slide?
Hit the arrow on the keyboard.
Oh, okay. So e-cigarettes were first marketed in the US around 2007. And since then, vaping has become a major health concern for all age groups. And according to the CDC, as of 2020, 14% of high school students and 3.3% of middle school students use e-cigarettes. And then as of 2020, 12.5 adult smokers use tobacco. And of that, 3.7 use e-cigarettes, and then maternal smokers account for 7.2%, and then of that, 4% use e-cigarettes. So while they're still fairly new, and the long-term effects of vaping is still vastly unknown, we want to know if maternal e-cigarette consumption affects birth outcomes and if it's a safer alternative during pregnancy. And then so throughout this presentation, we'll be going over 5 article reviews that analyze smoking behaviors among pregnant women, the effects e-vapor has on the offspring of mice, the impact of switching behaviors on birth outcomes, and if e-cigarettes or nicotine replacement would be a safer alternative during pregnancy. So for the first article, according to the National Institute of Health, about 40% of women quit smoking during pregnancy, but over half of them relapse within 6 months postpartum. So to understand if pregnancy influences smoking behaviors, the researchers recruited 47 voluntary participants from an ongoing smoking cessation study, and they obtained a spot urine sample during the first and third trimester, and as well at 6 months postpartum. And they used NIC-alert, which is a urine test that measures total nicotine equivalent levels and cotinine levels. And the total nicotine equivalent represents the total amount of nicotine in the body, and cotinine is a chemical that the body produces once it has been exposed to nicotine. And it identifies the level of smokers. So a non-smoker would be less than 10 nanograms per milliliter, and that's about 5 to 10 cigarettes per day. A light smoker is 11 to 30 nanograms per milliliter, and that's oh my gosh. I'm sorry. That's about that's oh gosh, I'm sorry. Okay, anyways, and a heavy smoker is as low as 30 and as high as 500, and that will be about a pack a day. And then the ratio, the CPD and TNE ratio is the actual amount of nicotine that is consumed. And the CPD is cigarettes per day, which is self-reported by the participants. So for the results of Article 1, as I said, the CPD is self-reported. So from the first to the third trimester, there was a 31% decrease in reporting using cigarettes. And then from the third to the 6 months postpartum, there was a 19% increase. So we should see that in the TNE levels with a decrease from the first to the third trimester, which was a 10% decrease. And then an increase from the third trimester to 6 months postpartum, which was a 91% increase. However, the CPD and TNE ratio from the first to the third trimester, there was a 167% increase. So this indicates that there was a misrepresentation or an underreporting of cigarettes per day by the participants. And then there was a 21% decrease from the third trimester to 6 months postpartum. And then for Article 2, they focused on the effects that e-vapor has on mice and their offspring, and if replacing tobacco with e-cigarettes would be more beneficial. So to assess this, only male offspring were observed because they are more susceptible to kidney damage from maternal smoking than females are. And then kidney weights and body weights were assessed and taken at 1 day post-birth, which is P1, in adolescence, which is 20 days post-birth, so that's P2, and then in adulthood at 13 weeks, which is W13. And then kidney development was assessed by kidney weights, the number of mature glomeruli, and albumin levels. And the study was divided into 4 groups. So the sham group was exposed to only room air. The SE group was exposed to only tobacco smoke. The subset group was at the beginning of the trial was exposed to tobacco, and then halfway through they switched it to e-cigarette vapor. And the 4th group was divided in 2, and they were only exposed to e-cigarette vapor. One half contained nicotine and the other half was nicotine free. So for the results of Article 2, the body weight of the tobacco group compared to the room air and the subgroup was 2.6% smaller, and the overall weight at 13 weeks remained lower among the SC group and subgroups. So this means that even by replacing tobacco with e-cigarettes, it doesn't necessarily make a difference. And then the body weight was not really impacted by nicotine or nicotine-free vapor, as they were about the same. And then at 1 day post-birth, for both vapors, nicotine and nicotine-free, the kidney weights, there was a 33% decrease compared to the sham group. And then the higher albumin levels represent how many mature glomeruli are in the kidneys. So the sham group was about normal, which is close to the nicotine-free e-vapor. So the 2 vapors, those were like normal, slightly really reduced, and then the sub was partially reduced, and then the tobacco group, the SE, was significantly reduced. And then for Article 3, they analyzed maternal combustible cigarettes users, so that's just the normal standard cigarette, compared to e-cigarette users and dual users. And a PRAM sample was used, so that's the Pregnancy Risk Assessment Monitoring System, of 79,176 women from both academic and private clinics. And these were of women who reported using tobacco or e-cigarettes during pregnancy who experienced a live birth with adverse birth outcomes. Combustible cigarettes accounted for 96.2%. E-cigarettes only, 2.7% of these reported to using e-cigarettes only 3 months prior to pregnancy, and then 1.1% reported using it during pregnancy, and then dual users account for 82. And the birth outcomes that they analyzed or observed for this one was preterm birth, small for gestation, and low birth weights. And then for the results, only e-cigarettes usage 3 months prior to pregnancy had no impact on preterm, small for gestation, or low birth weight. But there was a higher incidence of low birth weights for e-cigarette users compared to non-users, and the article did not provide data for non-users, but they stated that it was a 10.6% of low birth weights. And then there was no significant differences observed among dual users. And so this means that they do not necessarily increase the risk of adverse birth outcomes. And this is because, like normal cigarettes, they already double the risk. So they're not worse than actual cigarettes. And then, so they're basically saying that they're not a safer alternative. And then for Article 4, they looked at the effects of switching behaviors among women who smoke and are pregnant. So the study sample included 287 pregnant women, and switchers accounted for 11.5%. And these are identified as individuals who report using either or at the beginning of the trial and then report later something different later in the trial. And then quitters are obviously quitters. And then non-switchers, conventional or the combustible cigarettes were 48.6%, and then e-cigarette only was 41.7%. And they looked at gestational age, birth weights, respiratory distress, and NICU admissions. So there were some small variances, but there weren't any significant differences in gestational age, birth weight, respiratory distress, or NICU admissions among switchers and non-switchers. However, there was a higher NICU admission rate or percentage for non-switchers, but it's hard to identify if they were either conventional or e-cigarette because the non-switchers were in one category. So we don't know the difference between the two. And then quitters did have a 304 gram higher birth weight compared to non-switchers. So the study did not necessarily confirm nor deny any substantial impacts of nicotine consumption during pregnancy. And then for Article 5, the main focus of this study was to determine if nicotine replacement is a safer alternative to smoking, and if it will promote the adherence to smoking cessation. And the study analyzed 83 participants over 4 qualified studies. And the studies contained information regarding nicotine use during pregnancy, cottonine levels of women who participate in abstinence and use nicotine replacement, as well as the cottonine levels of women who smoke and also use nicotine replacement. I don't know why they would do that, but anyways, so the types of nicotine replacement that was used was a 2 milligram gum, a 15 milligram 16-hour patch, and then a once a day nose spray that contained 24 milligrams of nicotine. So the results for Article 5, the data was from a pooled estimate. So the only information really shown was the types of nicotine replacement and the levels of individuals who smoked and used in our nicotine replacement. And the mean cottonine levels were 73.5 nanograms lower in women who participated in abstinence with nicotine replacement versus those who smoked and used nicotine replacement. So the study suggests that nicotine replacement alone exposes pregnant women to less nicotine, and it can be a safer alternative and that it does promote smoking cessation during pregnancy. So for my conclusion, nicotine in general during pregnancy has been proven to be associated with many adverse effects, including negative neurological and cognitive effects and chronic respiratory issues that lead later into adulthood. And the effects of nicotine in e-cigarettes are still largely unknown. So the study helped identify potential adverse effects that could be related to e-cigarettes, including decreased renal function, low birth weights, small for gestation, and preterm births. However, further studies should be conducted. And then low birth weight was a consistent finding among smokers and e-cigarette users for all studies. And because e-cigarette users are also combustible cigarette users, it's difficult to determine if e-cigarettes alone pose a greater risk or impose a greater risk on adverse birth outcomes. And renal development was also negatively impacted by both combustible and e-cigarettes, and the renal function was partially restored and normalized when switched from combustible to e-cigarette vapor. But this still does not mean that e-cigarettes are a safer alternative. It just implies that e-cigarettes do not further increase the risk for adverse birth outcomes. And then nicotine replacement was proven to expose the fetus to less nicotine and improve adherence to smoking cessation in pregnant women, and that it can be a safer alternative. But in the end, every article stood by the CDC's recommendation that nicotine consumption should be avoided throughout pregnancy to optimize fetal development, reduce intrauterine growth restriction, and decrease the risk of adverse birth outcomes. No. Questions?
Yes. All right, I have one question.
Okay.
I can't remember if it was in your intro before you did the article, or maybe it was your first article that talked about it was like women would quit and then they would come back, like start
Yeah.
smoking again, for 3 to 6 months.
Yeah, it was like, yeah, within 6 months.
Just talk about why.
No, but in one of my, actually, yes, they did. In one of my articles, they talked about the stress of being a parent and all of that. And then also with the underreporting, it's also based on like stigmas. Yeah. And like, you don't want to report a higher one because you don't want other people to think less of you for smoking while being a mother. So.
And was there anything in any of the articles that talked about like when it causes damage to the fetus, like which part of the?
It didn't. And I think that's what the mice study was kind of aiming for, to determine like a point, but I don't think that they, yeah. Thank you.
Okay, right now. Yeah, but we talked about, I didn't all around. I know that. Thank you. I'm not as emotional. Learning a lot, Amy. You learning a lot.
Did you ask me a question? Did you ask me a question? Oh, okay.
So they've got, I don't know what this folder is, but they have all of them in, well, I guess there's a symposium presentation folder and then Daniel Hall, or the room number and then the time. I'm just pulling up the presentation.
back at 30.
Yeah, I gotta run the restroom. And then once you, I'll go and do it, but once you open the presentation, you go back to Zoom and hit share screen, and then you select which. You can either share the whole screen, but they've been sharing just the one that's about to be presented, and just click share. And then once you do that, I go over here and I make it big for them. But that's it. So, I'll leave that. I'm in the restroom. I'll be back. Bye.
Is it just a month? No. Yeah, it's a month, but you know. Where the elements very stuff. There was some, in football, so that it's really wonderful. I don't know, like, this would get more question, right? But I think it's definitely, I want to pronounce it. And, over. You were over there. Yeah, they were, yeah. They were. I was trying to figure out how the data is going to be. Yeah, that's my question. Because I don't think, but that's what it says, and I was reading. That's what I did, 25. But then, so I mean, okay, yeah, that's big margin. You know how things are, what will help you, like, yeah. For myself. That's what I'm so I feel that's pretty sure. No, okay, I'm not doing it. So I think the presentation game is and then maybe because I was interested in your so I was trying to get the answer. No. So that we can start. Oh, okay. Sorry, you don't have to very good. Yeah. Recording. Radio show. Oh, so then we met, like, I ran over here, so like, try to call. So what's your program? Major. I'm, production and. Engineering. Yeah. 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 When I said. Like, I mean. I know. Yeah, it's okay. Yeah. We're almost like, yes. Oh. Yes. Aren't you guys doing the thing? Yeah. Yes. Those are actual. That's what I mean. To my actual, like, yes. Yeah. So,
It's just a kind of like.
have tiny fans, but there's some style on the outside. Yeah, I read I read some of the, they all like, skin through, doesn't last. Exactly, that's what I was at the teacher, that's what I was saying. I don't personally, they can something different, we don't have to do that. Yeah. Okay. So what do I do now? I didn't do it, I didn't do it, so just exit off. Yeah. They said something like that, but this was she was like, yeah, like for the teachers. Yeah. So how many people have to be? One story. One story. Okay. Okay. 5 years, and I'll tell you where. We're just kind of different. Yeah. Yeah. Oh. I couldn't go to anywhere. Like, I think that's how the big is. Yeah. So I was very interested in that. I know. Well, I mean, I just absolutely want to say. For stuff like that. No, she can only tell you about it. Like, but don't like her. I think would say. I'm researched so much. Like the fact that I even did that research. I was going to tell you that this is that because of what I was research. Yeah. Yeah. This is people having it is that. Like, yeah. I was like, I was interested seeing the research things, yeah. Correlation. That was a month in a day for. Yeah. Is right, guys? Yeah. And so. Oh, yeah. I did that one. Yeah, that one worked. Oh, that one worked. And it actually be like, legit. Oh. Do I still have that app? The Piedmont app. Oh, yeah. I learned that myself. I haven't built the marketing copy. Oh, we're going to take the ATI. Yeah. Yeah. And. Yeah. And so I straight into that, I took those like screening things that they do. Oh, right now they're doing the whole kind of like screening thing. So did it after I was. This is my first symposium ever, actually. Yeah. Go and see what it's about. I'm just like, gonna go for it. No. Yeah. Fun. Yeah. Good. It's fun. No, I'm sorry. Did you start your ATI, the comprehensive assignment? Yeah. Which one did you do? The comprehensive, like the for like the week 9 or it was 8. And then we're gonna be 9. Yeah, but which one did you, we take the one that we did already? No, it's yeah, I did. I was this one right here. Yes. Please, I agree. Did you do the other one? I started with. That's the part. Oh, okay, for the RN predictor. She did the, what is it? I was just retaking it. Oh, okay. Look, one I have to do for the predictor. Oh, garden here. The comprehensive 2023 initial. I think that's the only one that, the 2018. Maybe. The 2023. Okay, maybe try that. And whenever you started, you can still call, right? Yes, I'm my own question. Oh. I got to an NGN question and I edited that out because I didn't feel like reading it. Just having fun. Oh. I have so much to do. Look at my list. I didn't figure out. I'm just ignoring it. Ignoring it. The edit. Yeah, I haven't. I could be in nutrition class, but it's nothing else. Yeah. In a few minutes, it will be. And must move. Hola, profesor Rowan. I'm good with that. Is that what I'm saying? Oh, I'm sorry. You know, what we were doing. And she wanted to try to see. Okay, here we go. And just use a timer and I'm talking and there's not. You don't know them, so. Yeah. I've been in the same class for 4 years. I don't like grade level, like, there's some voice knowledge. Yeah, I could like grade level and then be like, that's it. That's fine. Better like understand it. From then, I really can't. Yeah. I get a lot of them, scan them, all that stuff down there. I'm not doing one, I'm here to watch. HBO, scan them. So I was like, I don't know if this is a good thing or. I like. Are you gonna do it? You can do it. Yeah. Yeah, just like it's.
Yeah, you just have to change it with that.
Did you want to do
It doesn't have what you showed me. It doesn't have the share thing.
Make sure you all scan.
We're just back to the regular where I just.
So go to Zoom. So go to Zoom.
This one.
Yeah. And then, oh, that was it.
The other one.
Right here.
Yep.
Oh, you're in the right place. Just click there. Sure. And then click that little button there.
This one.
And then you can introduce her if you'd like to, or I can do it. I'm not here.
I don't have to do anything but arrow.
Yeah. I didn't do it. There we go. Yeah, you can use these arrows here.
All right, next we have Erica Escher, and she's going to be presenting about equine assisted therapy outperforming traditional talk therapy.
Good afternoon. I'm excited to share my evidence-based research project with you today. I'm Erica Escher, senior nursing student here at Piedmont University. 23 more days, but who's counting, right? Okay, the title of my presentation is Hooves Over Hands. My research was inspired by my own experience growing up with horses and animals and also observing my own children. This is continuing to play. Should that be happening? No. Sorry. Pause. That one does it in a time motion, I think.
I think if you go to slideshow, there should be like little check marks, and then you gotta uncheck it. Use timing,
We don't want to use
Can we do it
timings.
from the beginning,
and then you can.
and then I'll.
You should do
I
it.
think I'll be able to progress it from there. Okay. 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 The title of my presentation is Hooves Over Hands. My research was inspired by my own experience growing up with animals on a farm and observing my own children's reaction to animals when they were having a difficult day. How many of you here have pets? Everybody has a pet. You like to go home and stroke them and spend time with them, and you take pictures of them and you post them on social media. We have TV shows all about animals being heroes. So that was kind of inspired this research that I decided to do. My PICO question was adolescents with depression and anxiety will experience less anxiety and depression when participating in an equine assisted therapy program. What is equine assisted therapy? The more formal definition is up on the screen. But in general, it involves a human participant, in this case, an adolescent who is experiencing some form of anxiety or depression, or maybe bullying or trauma in their life. An equine, of course, a horse, and then a facilitator who would be a trained rider, trainer who had some therapy background. The goal of equine assisted therapy was to improve the health outcomes, to reduce anxiety and depression, to improve self-esteem in adolescents. The benefits were to improve balance, well-being, quality of life, trust, spasticity, to improve their self-esteem, give them a sense of pleasure and a greater sense of accomplishment. The objective of the research was to prove the benefits of equine assisted therapy versus your traditional talk therapy or group therapy, where you're just sitting and talking with someone. In this case, you have an animal and you're using more of your body language and you're forming a bond and you have some boundaries and you're creating trust there. So could a horse replace your therapist? Studies suggest that it's quite possible. It is the new up and coming alternative therapy. And we see it all the time in the hospitals now. You see somebody pushing around a little dog throughout the hospital, going to visit somebody in order to help them relax, to have a better outcome, better health outcome. We see them in nursing homes. There will be cats and dogs. It'll be kind of the house pet, and it goes around and it improves the way that the elderly feel. It's no different with children and horses. So you see them with emotional support dogs or seeing eye dogs. In this case, we're just using the equine or the horse. So Article 1 was a systematic review of at-risk youths with the common theme related to decreased coping skills and resilience. These youth participated in a 10-week equine-assisted therapy program, and the outcomes of the review reported higher levels of self-esteem than the reported following traditional talk therapy. So in this particular case, these children had been going to a traditional talk therapy or group therapy, and they simply replaced it with the equine, in this case, and reported high levels of improvement. It suggested that a promising approach for achieving therapeutic goals with the potential to improve outcomes even further. This particular program was a horsemanship program, which encompassed riding the horse, grooming the horse, having total care of the horse, and learning skills and developing trust. Article 2 was a randomized trial. It examined how animals-assisted interventions are thought to outperform the other sources such as traditional talk therapy and the group therapy, because they didn't rely on language alone as an exclusive medium for change, but rather the unspoken language. The focus of this group was on social anxiety disorders and PTSD, with limited to no relief in traditional talk therapy. The groups participated in an 8-week program with positive outcomes based on the participants' affect. So they were being observed by their affect and how the equine made them feel based on what they were seeing and observing. The review suggested that equine therapy was beneficial alternative therapy for this classification of clients. Article 3 was a qualitative study. This article described an alternative therapy which incorporated cognitive behavioral components for anxiety into the adaptive therapeutic riding program. It was delivered by certified riding instructors in a horse stable that offered horseback riding and horsemanship programs, which could be at the client's own pace, which this one I really liked because it was more adaptive to if you just showed up that day and all you wanted to do was brush that horse, that was fine. You weren't encouraged to move beyond that. If you wanted to ride the horse that day, that was great. But if it brought you a lower level of anxiety to just sit and brush or braid the mane or paint on the horse, whatever you wanted to do, it was at their own pace. This finding suggests a range of improvements within adolescents with a low self-esteem and undesired behavior. It was a 10-week program, and at the end of each week, there was a debriefing with the participant, their caregiver, or their parent, and the riding therapist, which taught them how to utilize the skills they were learning with the equine and setting those boundaries and how to use those when they were experiencing triggers of anxiety outside of the program, which I thought was really beneficial and interesting. Article 4 was a randomized clinical trial, which included horses and donkeys. The study evaluated early outcomes of a program in the Midwest that was a 10-week program designed specifically for adolescents struggling with mental health and family and home life issues. These were difficult topics, but the topics central to this program included skill building, such as leadership. So taking charge of the equine that you were assigned that day, having total care of it, learning responsibility, and leadership. Listening, emotional self-control, problem solving, and setting boundaries, and being more self-aware. After the 10-week program, the parents sampled reported improved self-esteem in the children, better skill building, and coping and boundaries. The last article really didn't conform to the research that I was looking at, but it did involve equines and mental health issues with adolescents. But it was kind of a bridge program that also didn't just incorporate your affect and you saying, oh, I feel less anxious or I feel less stressed, but they also utilized gathering the heart rate information. So if you come in and there's this big equine, your heart rate goes through the roof, but then at the end of it, your heart rate came down. So they incorporated that into the study, which I thought was very interesting. So I included it in this project. It was a 10-week program with 19 adolescents with self-reporting anxiety and depression. So these had not been diagnosed by a traditional therapist of having depression or anxiety or PTSD. It was just their own report. Hey, I feel stressed and I need some help. So that is what qualified them to be in the program. They reported anxiety and depression was a crossover design with the heart rate. Unlike the others, they found that after the 10-week program of riding, grooming, and caring for and taking care of the horse, developing a bond with the horse created trust and acceptance and improved their overall outcomes and the way that they felt. It decreased their hyperactivity. They have better attention, reduced aggression, reduced bullying, and better problem solving. The responses from both the parents, teachers, and the clients were overall more positive than they would have been with traditional talk therapy. In conclusion, based on the evidence that I gathered in this research, suggests that equine-assisted therapy has many benefits in improving the mental health outcomes of adolescents suffering from anxiety and depression, as well as other physical and emotional ailments. And I think that it should be considered as an alternative form of therapy. It's not currently regulated, so your insurance will not cover it. So there are a lot of barriers to making this more successful and more available, because it would be your out-of-pocket expense, unlike these programs that were funded because they were doing the research, made it available to the participants. We don't currently have that, so it would be something that would be out of pocket. I know it's utilized a lot with physical therapy, but we're looking at it from more of a mental health standpoint. So it's difficult to find a program. There aren't that many of them. If you do find one, you're probably going to have to travel a long way and be out of pocket a lot. And many of the participants would not have been able to afford that. My research supports that equine-assisted therapy is outperforming traditional talk therapy, even though it's not as available. The numbers do support that. And as a goal, I hope that if you ever have any anxiety or depression issues, that you will look forward to reaching out and seeing if there is a program that would be available, or maybe get into a trial with that. And maybe you could ride off into the sunset with less stress. Does anyone have any questions? Yes, ma'am.
So I have a lot of questions, but I don't remember.
Okay.
You went over most of it. The different mental health conditions that were most studied were anxiety and depression. Right?
Anxiety and depression.
Did any of the research talk about effectiveness in other? Like,
They did reach out about autism. Autism spectrum was on quite a few of the programs. And then some children who were experiencing a lot of bullying at school, and issues with behavioral hyperactivity. Those were studied. Most of the studies did talk about those.
did they give any suggestions for since our mental health coverage is individual, and this is not like a common practice, common practice. Did they give any suggestions for like what people can do with like home pets or something that might?
I didn't find, the question was about whether or not there would be other pets at home if you couldn't find a program. I didn't specifically see that in any of them. However, just my own observation with my own children and in nursing homes and whatnot, they enjoy seeing the pet as long as they don't have an allergy to them.
Yeah.
But yeah. Anybody else?
Quintana. Huh? Oh. I think it's just us. I don't think there's anybody there right now. But we're gonna still share anyway. Okay, who's that? All right, next we have Leslie Quintana. Did I say that right? Yeah. Okay, who is going to discuss cannabis? Where'd it go?
Right there. It's coming.
Okay. Cannabis products in childhood epilepsy disorders.
Okay. Hi, y'all. So I'm a senior here, a nursing student. Oh man, mine's doing what Erica's did. Hang on. No, you're fine. I got it right. Yeah. Okay, let's start over. So I'm a nursing student here. I'll graduate May 5th, hopefully. So I did it on cannabis products and childhood epilepsy disorder. And the reason why I picked this subject is because I actually work in a pediatric floor, and we had a patient that outgrew my floor. So he's an adult now, but for as long as I've been working there, which has been around 6 years, we kept getting him as a recurrent admission, and he had cerebral palsy. He had a bunch of things, but one of the things he had was epilepsy, and it was very bad. Like, pretty much it was like he would be there, he would have one seizure, another seizure, another seizure. And then on his last admission that I had him, his mom actually had CBD oil. And at the time I was like, oh, what is that? And then she educated me on it. And then she said that that was the only thing that has helped him so far. So that kind of was like, oh, well, that's interesting. And it's something that I think we're going to see later on in the medical field, because it is becoming more common. Back then I was like, oh, but now like I do see it. So it's something that I wanted to get educated on. So, does cannabis-based products improve the symptoms of children with epilepsy disorders? I had another slideshow I sent. I think it is the wrong one, but it's okay. I think I remember it. So over here it says PICO, but pretty much on the original slide, I had picked out some things that are main topics we're going to talk about. So obviously we're going to talk about CBD oil, and we're also going to talk about Dravet syndrome, which is a form of epilepsy disorder that is not treated very well with any kind of medication. And you're going to see throughout this, throughout my presentation, we do see a lot of people that did bring their child with Dravet syndrome. And that's pretty much because that's their last choice. They can't find anything else that helps them with it. And then I am also going to speak about this medication called Epidiolex, I believe. So that medication is actually an FDA approved CBD pure form that we're going to talk about. So I just want to let y'all know in case y'all didn't have any like medical background about it. So just in case. So, you know, epilepsy, obviously we know that it's a lifelong seizure disorder that can affect anyone, but kids are the large population of affected individuals with epilepsy. And then what causes a seizure is pretty much your brain is pretty much going crazy with the signals. They can't get in the same page. And then ongoing research exists today with individuals continue to test the properties of cannabis-based products and their effects on the epileptic population. So this is a review for my very first article. So this was conducted by Jazz Pharmaceuticals, and the purpose of the research was to investigate the potential anti-epileptic effects of cannabis oil, CBD, in children and young adults with Dravet syndrome. And the population was obviously children with Dravet syndrome. And then about the participants, the total number of participants were 199, ranging from ages 2 to 18 years of age. The participants also had to have documented Dravet syndrome and a failed medical treatment history for the epileptic disorder. The participants also had to have been stable before participating in the study. And that's pretty much, they have to be stable because they didn't want a patient that was already in a critical stage to be put through this trial. So the two controlled groups used CBD products as their treatment, which included CBD and Epidiolex. And Epidiolex is the other one that we're talking about. And then one of the control group had a precise dosage of 10 milligrams per kilogram, while the other one had a 20 milligrams per kilogram. And the third control group was given a placebo effect. Okay, so a limitation of the study, it's hard to conduct studies that include children due to parents being afraid of their child participating. And I did see, after I picked this topic, I was like, oh crap, there was a very limited research on just epileptic disorders. That's why I did include Dravet syndrome, because that is something you find very often. And it, like, again, it's because that's their last resort and they're just trying to find something for their child. The results of the study, so the one that included the 10 milligrams per kilogram per day dosage had 66 participants, and out of the 66 participants, the results were that 45 caretakers or individuals reported improvement in seizure activity, 18 reported no change, and 3 reported worsening symptoms. In the second control group that included the 20 milligram per kilogram per day, they also had the 66 participants, and out of those 66, 40 caretakers or individuals reported improvement in epileptic symptoms, while 17 reported no change and 9 reported worsening symptoms. So to conclude, pretty much it was saying that the one with the smaller dosage did have more positive feedback than the one with the larger dosage. And like anything in our bodies, we kind of have to have the right therapeutic level. So the review for the second article, so this was to evaluate how children with Dravet syndrome can benefit from CBD, and a little bit about the participants. The individuals that participated in the trial were ages from 2 to 18, and they had a standard dose of 20 milligrams per kilogram per day. And that was pretty common. You didn't see anything greater than 20 milligrams. So the study consisted of a randomized double-blind placebo-controlled in which 120 children with Dravet syndrome and drug-resistant seizures received a precise oral solution of CBD and their standard anti-epileptic treatment. The treatment timeline for the subjects consisted of 2 weeks of dose escalation, 12 weeks of dose maintenance, and a 10-day taper period. And lastly, individuals were followed up for 4 weeks because they also wanted to see the long-term effects of it. Okay, so to conclude that article, the limitation was that caregivers were solely the individual in charge of reporting the symptoms and frequency of the seizures. This could have led to inaccurate and recording regarding the symptoms of the seizure activity. So the results of the study said that 43% of the individuals that received the CBD showed a reduction in seizures during the trial. Only 27% of the subjects that received the placebo effect showed a decrease in the seizure activity. And it was also concluded that 5% of the subjects that received the cannabidiol reported becoming seizure-free. Some adverse symptoms included vomiting, fatigue, pyrexia, elevated liver enzymes, and overall somnolence. So for my third article, this was to review the effects of cannabis in the pediatric population that had epilepsy. So the targeted groups for this one was pediatric patients with the epilepsy, and a little bit about the sample. So the article was based in a review in which current researchers were evaluated and compared to one another. So it's very hard to find present articles, but you do see a lot of article reviews in which they did gather all their information and pretty much merge them into one. So one study contained 272 participants and another study contained 120 children and adolescents. So one of the primary studies that reviewed was a retrospective multi-center study involving 74 children in Israel in 3 different epilepsy clinics. A limitation was looking at different pediatric groups. It can make it challenging due to the dosaging in the different age groups. And the results of the study was that 52% of patients that reduced the frequency of seizures by 50%, and only a total of 7% of the population experienced a seizure aggravation. So only 7% actually experienced their seizures getting worse, but while the other 50% did see a reduced frequency of their seizure activity. So to review, so a little bit about my article 4. So this was to collect the information regarding the experience and knowledge of CBD use in the pediatric epilepsy. And the population targeted in the research was children with epileptic disorders. And a little bit about the participants. This was a total amount of respondents that were 166 patients. And out of the 166 patients, 76 of the patients were female and 90 of the patients were males. And pretty much why I decided to pick this article was because it focused more on the survey part, like what do parents know, what's out there? What is the pediatrician teaching these parents? Like, are they giving them all their options that they have? So a 34 questionnaire that evaluated in the demographics, clinical factors, seizure types, knowledge, and opinions of parents regarding CBD use in the pediatric epilepsy. It can also be classified as a cross-sectional questionnaire. And the survey also provided different results, such as knowledge from individuals about the CBD. Some limitations were that caretakers did report a lack of medical advice from pediatric doctors regarding CBD, and this led to a smaller population of the subjects that had actually tried the product. And you'll see out of the 166 respondent, only 16 individuals reported being on CBD, and 6 out of the 166 reported previously using CBD. And out of 16 patients currently using CBD oil, 9 reported a declining frequency of seizures. Symptoms reported from these patients were mild, such as headaches and nausea. And out of the 166 patients, 119 individuals were aware of the approval of CBD use in Thailand, but only 81 individuals were aware of the medical usage of CBD in the epileptic disorders. 128 out of the 166 participants did express willingness to participate in future CBD clinical trials. So for my last article, this was aimed to provide an up-to-date analysis to which the benefits and harms of cannabis-based products for epilepsy are investigated. The method of the study was to update a systemic review by evaluating different studies that were published up to May 2019. And that's again based on that other factors that we're talking about, that a lot of the time that, oh, I lost my train of thought. Yeah, that a lot of the time when I was looking for this, a lot of the articles were based on past stuff. So a little population that was, the population that was targeted was children with epileptic disorders. And about the participants, a randomized controlled trial and a non-randomized study involving children where epilepsy were administered a CBD-based products. Some were given pharmaceuticals and others were given a placebo. And I did see that reoccurrence a lot. They were given a placebo, and I think that has to do with it being such a touchy topic. They don't want to get any mixed results. So they want to be sure that if it was working, that it really was working. So about the study. So the review investigated 35 studies that evaluated the benefits and risk of cannabis-based products as a treatment for children with epilepsy. These studies were either randomized or non-randomized studies. A limitation in the review is that many of these studies were evaluated Epidiolex, which is the actual one that is FDA approved, which is a purified CBD, compared to generalized cannabis-based products. The results of the study, 23 studies reported seizure freedom with cannabis treatment. And on the downside, 3 studies did report that no child became seizure-free. 14 studies evaluated the frequency of seizures among the pediatric epileptic population, and it was concluded that CBD heavily did reduce the total monthly seizure frequency compared to the placebo effect. And to conclude, the most studies or reviews of the studies show either positive effects of CBD products in the epileptic population or no results at all. The most significant side effects that individuals reported throughout the research was somnolence, and very few deaths or hospitalizations were reported in some research, but it was unrelated to the usage of CBD. So their cause of death was not figured out. And recently, the FDA has approved using one purified form of CBD for children who do not respond adequately to treatment. And the drug's name is Epidiolex, and it has been shown to improve the symptoms of children with severe cases of epilepsy. And any questions? No, okay. And oh, okay.
Did any of the articles talk about the efficacy over time? Because I had a friend whose grandson is autistic.
Mhm.
She thought CBD was a miracle drug for about 6 weeks.
Oh.
And then all of, he was still alert and everything was great, but it didn't last very long.
Mm-hmm.
I just wondered if you found that in any.
Any, I did, well, like most of the articles that I did find, the kid, it would be cool to see one that actually did follow a kid longer, but I think the longest that I did see that tested out long-term effects were, I think, almost 6 weeks or something like that. So I didn't see anything greater than like 6 weeks or, yeah, I think the one I did do was 4 weeks. And I promise it looked better when on my actual one that I sent her, okay? Okay.
I've tried to catch each of these, but of your 5 articles,
Mhm.
how many of them were in the United States? Were any of them?
A lot of them
Most of
were,
them,
yeah, except one of them was in Thailand. And one of the article reviews, one of them was in Israel,
Okay.
like, but a lot of the research was conducted here.
So based on your experience, you said you've been working in Peaks for a while.
Yes.
Are you still actively working? Or
I'm still working there, yeah.
where do you see this, where do you see it going based on your experience and based on research?
Well, like for me, when I first, it was actually kind of cool to see because she knew all his aura. So that means she knew all his pretty much triggers. So when I was in there, he was about to have one and she was actually able to just kind of climb up there, give him his little, and it stopped, like it didn't happen at all. So when I did come out, like the nurses were aware of it. So I think that I think it's becoming something that's more normal, is being more normalized. And when I came out, I was like, what is she giving me? Or no, because most of our patients are stable, but this patient was like even at 19, our pediatrician was still accepting him because he had been one of our patients for so long. So most of our patients are stable and they don't need that, but for him, he did have, I think it was cerebral palsy. It was a bunch of things. So he was the only one that actually encountered that I saw it work on him. Okay.
Right now. Yeah, even the one that you first posted. And then I can email me your slides. Well, you can your slides. You don't have to write seconds. I have my. Thank y'all.
I think the next one will start at
1:40, 1:30 or 1:40? I've got 1:40. 1:40. This was supposed to go at 1:30. But the next one's 1:40.
Should I shouldn't close the Zoom though, right? Just leave it open. Okay.
No, then we have to log in.
Yeah, I'm just gonna leave it.
I'm just gonna forward you the email.
That works.
Like the whole conversation, but it's. I won't read it. I'll just put it. The slide. Jake, actually, there is. Yeah.
But I'm calling it the start. Well, I'm an expert. Per year.
No, I'm good. So you want to just. I'm like, I'm good. I'm not really sure this is gonna be on school. Oh, no, you're good. Okay, so on the first one I sent, that was my original that I sent her, and then I noticed, did you see some of the flaws? Yeah, so I noticed that, so then I emailed her, and then I sent her another one, and then he was like, okay, that one was good. But then I came to my practice session, and then I had to do a little tweaks here and there, I removed the pico, and I did like a key term thing. And so I added that, and then she said, if you send it to me now, like, I'll put it on, but I guess it didn't. I guess they were all named the same thing. Okay, sounds good, I sent you that one. Thank you. Erica. Good job. That's all. Good job.
And then I'm. This was session 3.
I didn't know that changed everything.
I didn't either. I didn't take files. Except for this, you know, there is this set of files. Why don't you put it in this store?
I think I'm not.
You got two of them. When they see them, you don't do the same.
I believe I'm done judging. So just.
I don't know who the time is. Okay. No, like, I think spring. I just want things. So, the only I just. Yes, now I'm very glad that you might have to. So, I think we're all going to like a lot of them. Don't play. Wow.
So, what time was the next one? 1:40? So it's already started there. So here is this one, but it seemed like you have more sheets than that. So why is it not?
There should be 3 of them.
I know, but I only see one. That I don't know. But you'll double click this
And then just,
and let's see.
and what were they unclicking to, so it didn't go automatically? You know what? It's not here. Somebody can help you.
Yes, she is. She's right.
Oh, yeah. What do you unclick so it doesn't go automatically?
Oh, so, yeah, I don't even know how it got clicked, but the first time.
It sounds like it involves to that.
Yeah, so you click on it. On the actual.
We're supposed to have 3 for the next session.
I know, but I don't see one, and I mean, that's right on that.
Once it comes up.
You just double click that.
I did.
Ah,
Oh, but there
And
it
they put
goes.
a slideshow. The slideshow at the top bar, right next to it.
Sorry.
No, you're good.
Oh,
Over
right. Duh.
right here, and then use timings, take that off.
Okay.
There you go.
Oops.
And then what she told me to do was, you go down there to the Zoom, which is right there. Okay, and then
You can probably turn the recording.
whenever they're ready, you can do
Share.
screen share, and then you can also blow it up for them
Okay,
after you do that.
okay.
But I'm just wondering where your other.
Yeah, should I find out?
I just don't have them now.
Well, in those volunteer sheets, there's phone numbers. But I don't know if you call Julia Schmitz, if you call IT.
I went for it.
Writer reporter, combination. Thank you. You're welcome. The one that I was supposed to say.
Yeah. I don't. I'm looking very, yeah. Yeah, no, it's not that far, yeah. And then I went to the. Yeah. High school? I did too. I graduated from, yeah. So when? It was a while back. Yeah. I think I have all these new teachers now. I didn't graduate. Oh, and. Freshman year and then not sophomore year and then I went to. Really? Yeah. I'm like, it wasn't bad. It's just legit, right? Or don't be honest about what. And it was, like, it was, yeah, it's same, I never been. One of my friends cameras, but like, it was fun. It was kind of, to Reagan County, was it for that, or, yeah. But I have all of my cousins and my dad's over there, so I went there. So that makes sense, yeah. So that's only like, yeah. Is there a weird, like, because one time I reported, that's what I said, this one time I remember, we had this, I don't think I had that class, but it was a criminal thing class. So they had that class and they had that chicken there because they were doing something. Test chickens. Remember there was a pond, when I went there, there was like a pond. There was a pond there. They took the chickens, painted them that color and they hung them. And there was a racist, yeah. Yeah, and that was during my class. And like, I was like, they have killers. Oh. Yeah. And like randomly one was like, hey. And so I'm talking to her. Oh, he's from there. Oh, really? Oh, okay. When you're talking good, I went there. Yeah. I heard good things about it because my husband graduated from there. Oh, cool. Yeah. Okay. Sounds good. But fairly easy question. It's like there's someone. Yeah. If you want me to. It's up to you. What do you want? It's really fair. I mean, I can just bring them if you want. Okay. So I chose the topic because I don't know if you saw, I did have encounter with it while working in my board. So I've been there for 6 years and this patient he had super policy, something else, he couldn't walk that long. And he was very special. And every time he was admitted, I had him there for like 5 years. I was continuously seeing him. And it was so much that like his mom would call one of her neighbors and like, okay, let's still be admitted. And they would still take him, even though he was like 19. So 19 was his best. After that, we would see him. So she actually did do CPD for the one. It was something that she couldn't find any staff for. So pediatrics that one sort of. So yeah, so that's why I chose it, is because yeah, this one time I was getting ready to get his stuff, but before it even started, she was able to start seeker. And it was because she gave it. Yeah, that's why I think the reaction to findings. So I think it was pretty cool. So that's pretty much why I decided to research on it. And then during my research, it was pretty interesting to me that it did have a positive effect. It's kind of, so it kind of makes me compared to me that it did show positive stuff.
My son used to treat anxiety.
Oh, really? Treat anxiety? Yeah.
He has high anxiety and doesn't like medication.
Yeah.
So he used to treat that. He said it works good, but you know.
I'm not diagnosed, but I
Oh, he has.
highly believe that I have either autism or ADHD
Yeah.
or the combination form. And I use it to help me like focus on things.
Yeah.
It's literally the only thing that I've had,
Really?
because I don't like the idea of like consistent medication
Yeah.
that I take on a daily basis, just because like, I just never really liked the idea of that. And so I wanted something that would be like situational, basically. And it was like, if I physically can't do work, like that's like the main thing that helps me.
Well,
That's
good.
kind of why I wanted to come to this
Yeah.
one, because.
Do you use
I
a
have
specific one or do you
Not really, I mean, my boyfriend kind
kind of knows
of
what
knows
he's
what he's
doing?
doing.
My son is the same way.
Yeah.
Because I think he knows that he's like, he's just for the.
Yeah, I was busy and I didn't know where to like get anything that would work. And he was like, here, take this. And I was like, you're amazing. So I
Yeah.
just,
Well, that's wonderful that you found something that
yeah.
that helps, you know.
And that's what I felt like, kind of when I was like, people, that's like, if it changes the way we do that, is like getting rid of that, like,
Yeah.
stigma.
Yeah, I was gonna say, I think it's, there is, and that's why I was kind of scared at first to it, because I was like, oh,
I think it's a great thing because that's especially what, and that's the term,
yeah,
young people versus my, that's what
yeah.
So we never did that. I mean,
Yeah.
the parents should do.
And I,
Because they're like, oh, you're George, you're going to. You know, it's just different now.
it is, like, there's kind of stores and you go.
Expensive.
Yeah, they
The
are.
good, I think you can get, stuff at the convenience store, but I'm, so I'm scared of that.
Yeah.
You know?
Yeah,
I just think that it's like the tiniest bit of CBD and like filler or something, so that they could like mass produce it. And make
Yeah.
enough of it, but, like, you want like the good stuff, it's not cheap.
no.
But it's not
That's
safe,
not something it can be.
because I know that I had a friend that used medical, not medical, she used marijuana to synthetic. But it drove her nuts.
Yeah.
But she had to put in an institution for a while, and I guess it was just like for something that, she bought it from convenience store.
Yeah.
Yeah,
I
it
get
was
it.
cheap,
But,
but.
yeah.
Yeah.
Hey.
Yeah. Right.
But, so I hope that with, as more research comes out, that it was something that. Because I didn't, when I first walked into that, I was like, yeah, you know, like, but then I came out and like, then she's like, oh yeah, like she has that, she was like, so I hope it's like more normalized or something that people can get more educated on, I guess, but it's like. You know, like, so I think it'll be interesting to see, and now with the FDA, I think that was recent. I forgot, but it was recent, that dialect was recently approved, and, so I'm hoping with that, other people that more. Because it does help with hyperactivity. And it's a lot of anxiety, autism, and ADHD, like hyperactive stuff, yeah, so. Awesome. Thank you.
I was like, I wanted. Yeah, more research done, so like, also music research, yeah.
Yes, and most of the research, it was crazy because most of the research was old, really old, but like the research. And the research I found though that, they all had like positive stuff, so it's like, why wasn't it?
Why it's so like stigma around it.
Yeah, but,
Like,
yeah, it was hard to find the positive. I think so, I think sure.
I think some states are different now, like they,
Yeah.
it's more like a state driven decision. but,
Yeah.
Like, in most places, like if you get caught with any like, little bit of marijuana, you can literally get felony.
Yeah.
Hey, how you doing?
Good.
You graduated this semester, right?
Yes, I am.
Awesome. Good.
At least that's the plan.
I hope, I hope. Hey,
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 how are you?
all right.
Good.
All right, so this thing is still
I'm the
recording.
physicist, and I don't know what that means, except that they just sit here and I'm talking to
Yeah,
you. Absolutely.
these used to be two separate rooms back in the day. The wall was right there. And back in 2011, they tore those out and handed this over to the nursing school, so they had these gigantic rooms.
Thank you very much. I didn't even know this existed. I haven't been on the side of that.
No, they kind of booted us out over time. Sometimes Dr. Plaisir teaches down there, always in 301. Sometimes I'll go down there too, if they need me. But these classrooms this way are pretty much either health sciences, nursing, something, one of those two. And then they took the offices too over the last couple of years. So now that's why we're in Arundel. Although our offices are nicer now. So
They are very large.
they're really nice. And, oh yeah, I also found out in the summer of 2018, those air conditioning heater systems are really outdated. So be very careful. They are. When this building first opened in 1965, because Max White was freshman that year at the building, he said there was no air conditioning. Wow, people must have roasted back in those days.
I think that's fairly common though.
Yeah, I think this is. No, you're right. I mean, it's just, yeah, I think it is. I think that was the norm back then.
That was one of the things the German students talked about.
Yeah.
They did nothing, maybe at home, a well-to-do person would have air conditioning in their home. But their college and schools are not. At all.
Yeah, I noticed that in Spain, but. God, heat and humidity down here. It's so different, man. It would be very different to operate that way down here now. I think people would have issues.
I agree. I would roast a lot on these buildings.
Yeah. Okay, when we start, I don't know, hopefully Amy and or Anna will be here. It's been a push, but if not.
You know what though, Dr. Friday,
Yes.
one presentation of all. Time slot.
And that's because I can get any.
Okay.
So.
So do you
It might
think-
just be, it just might be you now.
Yeah,
okay.
that's the only one that's there.
And so if that's the only one, you're our guy. And.
So make sure everything's still okay.
Oh, yeah. The Zoom is up.
Yeah.
Okay.
It's still recording.
Okay.
And when it comes time for it to kick in, oh Lord, wherever that screen is, oh, there it is. So when it comes time for this to kick in, then I'll just click start video, the share button, so he can go over his PowerPoints on the recording.
There you go. I just make sure everything was still up and running. That's all.
Oh, yeah, everything's.
Presenters have their PowerPoint presentation. How would they get, is there any way we could still add it at this point?
What will
They
probably
have to
happen is
pull it
I
up
hope
on
they
their
have a
own.
memory stick with them. I know
Okay.
memory sticks aren't as common today, but if they've got one, or
My understanding, I thought everything was supposed to already be on the desktop for them.
it was supposed to be, but they
Yeah,
just didn't.
there's
send
3
it back.
presentations at 1:30 and there's only one PowerPoint.
Yeah.
Okay.
So the other
Alright.
ones just either aren't gonna show, or they just, I don't know, they're gonna bring it with them. So the other option is, and I did tell them by email, you can email it to yourself, go into a browser, access it. And if you want to avoid two-factor authentication, maybe something like Gmail or live.com or Outlook or something.
Or they could theoretically even log in on this computer, maybe pull it
I'm
up in their email or something. I don't know.
not sure.
What's the
I'm not
best way to
sure.
do it? I'm not gonna worry about it. If it
But-
was supposed to be here.
Yeah, they're supposed to be here and
There you
if
go.
they're not. Yeah, everything else is good to go.
All right, then.
Thank
Still
you.
be going back and forth.
All right, that's cool.
Thank you.
You're welcome.
Yeah, amount of emails I've sent those to. Ugh. Oh, Des, as I sometimes say in class, half the battle's just being there. And if you're just there, you'd be crazy. This world is such that You're on time every day. That's amazing. I think I told you guys once when I was in banking, I actually got promoted in my first 4 months because they were impressed because I came to work every day. It was on time. I'm like, I thought that was a requirement.
Well, it's funny because post-COVID, and it's probably been a year, probably 6 months, if you had those Athens on 441,
Oh,
it's
yeah.
like some of the poultry. $1,000 bonus for punctuality, and I'm like, what, you get more money if you come to work on time? Or, actually showing up, every day, and
Our first year back, the attendance was so bad, especially for the freshmen.
Yeah.
And it took a couple of years.
well, I would have had it, and I don't usually make a big deal in my office, because most of the people are on the road all the time, and I'm sure we
Yeah.
impose them all kinds of contact. But our newest hire caught on very quickly that, I know if you come in at 8:15, that's okay, and so now I've got to kind of deal with that, because she hasn't really done any traveling, and she doesn't have any job time, and I'm like, we already get 3 free hours every week, because we all get paid for 40 hours a week, even though we get up at 2 o'clock on Fridays.
We're still doing that on Fridays? I wondered about that. I was scared to ask, but
We were all afraid that the president might put an end to that, but there's a lot of people that like that perk well enough to stay. and,
I understand. I don't blame them. It's just a Friday.
So
Most college campuses pretty much die out in the afternoon.
I would just say, well, and like the 2-year schools, they're closed completely on Fridays. They do 10-hour days Monday through Thursday, like
Wow.
admission staff and stuff.
Huh.
Yeah.
All right. I didn't know that.
And North Georgia Tech, that campus is dead on a Friday.
Wow. I didn't know that.
Yeah.
I went to, well, I was a community college. Those are maybe years ago.
Yeah, and things have probably changed, but yeah.
We'll wait it out here.
Yeah, it's 1:40.
Minutes.
So they got-
I'll wait. Hopefully one of those two show up and if they don't.
I just do my
Show time for you.
Yeah, buddy.
Be your judge. Bruce is not here. And from what I've gathered, because I've asked around, he was involved in Athens. Probably at this, he wants something to do with administration. He's doing a lot of the personnel stuff.
Saw him this morning. Yeah, he just asked me about it. Had it too.
Did he say he was going to Athens?
No, he didn't mention.
Okay, yeah, I think it was the last thing. Because I just looked for him a little bit ago, kind of wondered, like, I hope he's around. Because they do this. They just sometimes send them out. But I'm here, Dr. Kelly Williams is supposed to be here. But if not, get me.
All right.
I'm doing all your write-ups electronically, submitting them. You graduating this semester, you got something lined up, going to grad school or what?
Not grad school, hopefully a job. I'm looking into the GBI, that's line number 1 spot right now. I won't be taking my test until May 9th though. And then I have another job, Hall County, kind of working with right now for a high-scene technician. So those are my 2 big ones right now. I'm trying to stay out here in Georgia. I don't want to go back to Texas that badly, but really. I mean, I love Texas, don't get me wrong,
You
but
know what? You should her in the same boat. She's gonna work here. It's like she's from Texas. She's not gonna go back to Texas either. It's like, is it that bad? I think it was a family thing. She wanted to be over here for a while longer. I don't know. But that's fine. And the GBI, I'm sure Bruce told you, as I've told you guys before, they're hiring crazy. They hired 3 of my students last year.
really,
30,000 caseload backlog. They don't have people. COVID really took a hit out of them. And on top of COVID, they also had issues with just retirements during COVID. People just had to get out of here. And you only need to put in like, I think 20 years in the agency to get pensioned. So they lost a lot of people. Some of them might have been on the beds. And so all these cases that they just kind of sat on and just piled up. And they need to get those cases resolved because it's a GBI, they're not investigating jaywalking. So you're talking about drugs, murder, sexual assault cases, a lot of cases.
a lot of really bad stuff.
Yeah, the bad stuff that you absolutely have to adjudicate. And if there's backlog on that, if they don't get that resolved, and you already know, as evidence accumulates, it's not dealt with, it either disappears or the people you need to talk to have long bad memories. It just gets worse. They're already behind the 8 ball, and I'm honestly a little worried that some of those cases are probably going to die because of this. I hope that's not the case, but we'll see.
Maybe they'll get the hiring resolution done when I get there. With me.
I hope so.
I would love to go work there for sure.
Yeah.
Oh,
Um,
big. Especially with Mr. Willis as my advisor, he's had so much experience.
oh, yeah, he's,
Influence on my.
ugh, Professor Willis has been such a godsend for us. He's gotten so many big guys hired. I think we have 100% job placement, so you're not gonna have a problem. in one or both of those agencies. And I'm hoping, oh gosh, I hope Amy and or Hannah also show up, but let's, they got 10 minutes. We'll wait here. Oh, we got somebody in here. Okay, maybe I should do a sound check or something. I'm going to Chad. All right. This looks like Dean Tamanera. I think that's you. I guess. Can you hear me right now? You can just type it in chat. Hopefully you can hear me. Yeah. Awesome. Perfect. Good. Thank you. All right. So what will happen is when it comes time for the speaker to come up, I'll hit the, the video button. Right now, the video is still incognito. I'll hit the video button and then I'll hit the share screen button and we'll go right into the PowerPoints because it's still recording right now as I speak. So it's just recording. But what we need is for you to be able to, for them to be able to see the PowerPoints, whoever is zooming in. And they'll be able to hear you because I just done a sound check and they can hear everything. So that means the mic's working good. And, I've told you guys before, if you ever want to use clickers, here's a clicker, but you don't need to use one. Most students don't when they're doing presentations of this type. But if
probably sit at the thing, I have to flash cards.
Oh, my goodness, you listened to me. All right, awesome. Yeah, all right, you're good to go then. And 15 minutes, I think, is the time allotted. Let me double check on this.
I put 10 minutes for mine,
Yeah,
but I think I can easily fill 15 minutes and that's needed.
You want to change it to 15?
That's
The other two were 20, yours is 10, but you want 15 instead?
That's fine. Yes, that's fine. I ended up getting a lot more data than I realized PowerPoint came out all on. It works. Use the bathroom.
Oh, yeah, sure.
Sorry.
So I'll wait until a little after 1:40. Hopefully Hannah and or Amy will show up.
Okay.
And, I emailed them both and told them and said, make sure, don't have them bring them and or email them to yourselves so they can access them.
Okay.
Usually when they're doing them in my class, they'll email them to themselves. Like I said, people just generally don't use memory sticks that much anymore. I think it's just everybody's acclimated to using the cloud. So that's just normal for them.
Yeah.
Hey, how you doing?
Good, how are you?
Glad I presume. Yes. Welcome. Hey, how you doing? We got to pick your 3 presenters today. One is here, the other 2 are not.
Well, you're here in just a minute.
I hope. I asked them to be here. They're in my class. I see you guys in class, but I don't know if they'll show up. They have not sent in the PowerPoint, so I just let them know that if they come, make sure you bring them. Either email them to yourself or memory stick or something. Yeah. And Oh, awesome.
Sit right back there.
Yeah, you can just sit back here.
And I just use my phone. And then when you're at work, you just sit back here and. Tell me after you think I'll contact you. So if either one wants to. Not sure if he has- And he changed it to 15. Do you want me to do it? Okay. So what I did, yeah, she took the timer and the clock. And set it for 15 minutes when he starts. 15? Yeah, he's gonna do 15. The other two girls were 20. You know, what do you think right now? Ooh, here comes all your audience.
All righty.
Yeah.
Oh, it's. Boys have arrived.
This
one's there. Jasmine.
What's pretty like, well, you, yeah, you, I didn't know if you were.
Oh, he's a cross step.
And then when you guys walked in, I realized that they had it. It's usually like they're- Well, and then when they're having two people some coffee, they're getting on the. It's about all the way. Relax, who I did. Wait, wait.
2 more minutes, sir.
You might be a solo act.
Oh,
Yeah.
I'm intimidated.
Okay, yeah, no.
I'm saving on my phone and I'm using that to the rubric. I really am paying attention. Not taking speaking for it. I feel so confused when I'm on my phone and they're trying to present.
Oh,
But that's where my rubric is.
yeah, I'm using my iPads to do this.
You guys had clocked in, you want to stand? Oh, everybody else. You got it? You need it?
I like my senior capstone class.
Coach? So handsome.
What's up, Dave? You know, like credit?
Yeah, Miss Desmond. Gosh.
Boy, wonder.
He's supposed to be 1 of 3, and he's the only one here, so we'd be ready for the.
For you. No, we're not doing that.
First.
Yeah, that's what we're doing.
Like right on the, you know, but tomorrow.
Minutes.
I'm satisfied by what today. Did you get any free Yeti when you went there? Yeah, you're not gonna trip on that. Got the whole group. I don't know. How about this?
Everybody showed up.
All
right.
I'm just shaking.
All right. All right, everybody, welcome. We're supposed to have on paper 3 speakers today, but we have 1 speaker here. The other 2 are not here. So I'm going to go right on ahead and go to our speaker. Okay. This is a graduating senior in forensic science, Desmond Stallings. He's being sponsored by Professor Willis, and I'm going to be introducing him. And he is going to be doing an introduction to synthetic blood and its accuracy in crime scene reconstruction. And let me hit the share button for those folks in attendance here. Let me click the share screen button. Voila. And I'll go ahead and there we are. And perfect. All right. I think we got everything in here. All right, Desmond, are you ready?
Yeah.
All right, let's do it.
Hello, everybody. My name is Desmond Stallings, as most people are familiar with, and I did my senior capstone and research on the on synthetic blood and its accuracy in crime scene reconstruction. So, down. Hopefully that doesn't mess with the Zoom call. So, for the introduction, basically, in crime scene reconstruction, you usually are going to want to use authentic blood because it's important. You know, you find it at every crime scene. It's virtually all over the place when you're criminal justice or forensics related. And it's very like typical, especially educational environment, but also in a laboratory for crime scene reconstructions to be done. This is just a model like the crime scene, or for educational purposes, it's to get an idea for how blood behaves when it's outside the human body. But authentic blood, it has a lot of downsides to it. Obviously, it's biohazard, so it can have hazardous diseases in it. It can also be really hard to store because it is blood. It can rot, it can clot up because of the components in blood. And synthetic blood solves these problems, but it does also have its downsides because it's obviously not the real thing. So my research is to find out if synthetic blood can really serve as a substitute in crime scene reconstruction for authentic blood. The important questions I plan to answer with my research was, can you use synthetic blood in an educational environment? Can you use synthetic blood in a work environment? And should synthetic blood be used to replace authentic blood altogether when it comes to this kind of stuff? So my hypothesis for my experiment was basically, well, the hypothesis is that there won't be a significant difference between the authentic blood and synthetic blood. Made this my null hypothesis because synthetic blood is already very widely used today and almost everywhere, including here. So I figured this would be the most reasonable outcome for this experiment. And the alternative hypothesis is that there'll be a significant difference in data between the synthetic blood and authentic blood that I tested. So for a quick literature review, did some research on like other experiments that have been done in the same category. This one right here is a commentary on synthetic blood. And it's basically talking about its benefits and how it's better than authentic blood. As I mentioned earlier, authentic blood can be hazardous. You know, it can contain things that you don't want to get on you or inside of you. Dangerous in that it's not very good on the shelf life. You can't store real blood for long. I think it's 40 days maybe that you can store before it goes bad. And then there's also ethics approvals that have to be, especially in the educational environment, you have to be able to get approved to use real blood for experiments. And then also, if you have synthetic blood, it's cost effective compared to having the real deal. And some more on this. Basically, this first part is saying that synthetic blood is very useful, has a limitless potential. But synthetic blood, in the second part, it needs to model certain characteristics of blood if you want to expect to get accurate results. And some of them are listed right here on this line right here. Viscosity, surface tension, and density will affect how blood, flies through the air, how it hits the ground, how it shapes, it forms a shape, it ridge patterns. There's a lot of stuff that goes into it, obviously, but those are going to be like the key points that you want to get when you're making synthetic blood that can be used to reconstruct crime scenes. So, for the experiment, I have basically two big parts of my experiment that I wanted to test. It was the physical properties and the blood spatter test. Now, both of these experiments included sub-experiments within them to test the different components of blood and how it behaves in certain environments and stuff related to that. So this was the first part of my experiment, physical properties test. I wanted to see, so I have synthetic blood, authentic blood in our forensics lab, and I tested the viscosity, density, and their drying time. And for a blood spatter test, I wanted to model what you might see at a crime scene. So I picked two of the most found patterns we find at a crime scene. So cast off into impact, which I'll get into in a little bit, and then passive drip, which is just blood dropping onto the ground. So for the first part, my data is density and viscosity. And there's a lot to read here. I'll sum it up for you though. Basically, I tested the density a very simple way. I filled a graduated cylinder with a known volume of blood. And then I weighted on a scale, and then I took grams, divided it by the volume, got my density. As for the viscosity, I basically, very complicated test, not really. But as you can see on the screen, I had that same graduated cylinder. I measured the distance from top to bottom. I took a metal marble and I dropped it in there. And I basically measured the time from the top to the bottom to see how viscous the samples I were using were. And using this equation right here, I could get an actual quantitative data point that we can compare. So I will mention though, before I show the data, that real blood is known to switch between non-Newtonian and Newtonian behavior. And that means its viscosity basically can change. So on here, we have a list of different liquids and their viscosity. Blood all the way up here, and then CPS is semi-fuzzy. And it's pretty high up, pretty close to water as expected. And so that's where I wanted to find if the synthetic blood was accurate, it would be close to that range. So here's the first point of my data. First, just got the density, nice and simple with my graduated cylinder. You'll see that synthetic blood right off the jump is a lot more dense than authentic blood. And down here at the bottom, we have the expected authentic density, which is about 1.06 grams per milliliter. So, and I also, for all these experiments, I used real blood, and I measured that too, just didn't take it off the internet. So here is my tables. The top table is authentic, bottom is synthetic. I put that in there. My apologies, but you can see that it traveled through a lot faster on the top one than on the bottom one. So right there, it's not a big discrepancy though, but you will notice that both of them are extremely lower than the expected one on the chart that I showed earlier, which I believe has probably to do with the fact that it's already outside of the body and that the chart probably took into account your blood while it's still in the body. For my drying time experiment, this was just completely visual. I took 3 samples of each of the different blood types. I put them on a piece of paper and I just watched them, see when they started to dry, when it started showing signs of drying, and when they finished drying. As you can see, synthetic blood, it dried a lot slower than the authentic blood. And my expected time was about 45, 75 minutes, depending obviously on the temperature and the room you're in. But still, that's a pretty significant difference between times right there as well in the physical properties test. So on to the bloodstain patterns. So I spent most of my time in this experiment on this part, on the passive drip. This experiment basically included me taking a spoon and a meter stick, measuring different heights, I would drop blood onto the spoon until enough built up to drop and fall onto the paper. So this would accurately represent someone, they got a cut on their arm, blood's coming down, it's building up on the fingertips, builds up, drop on the floor. And so I took a lot of data points with this one. That's where I spent most of my time just to see, because I felt like I could get the most points. And here for the data, you can see that for the authentic blood, the drop stayed very small. And probably see it better on this slide. I'll go back to that one. But the drop stayed very small on this one. These are all measured. These ones are measured from 90 centimeters, which is about hip height. I felt like that would be the most accurate representation of how far it would fall. And it stayed pretty close together. The average 7 millimeters, 10 millimeters, 11. But on the synthetic blood, you can see that it almost doubled the size in diameter for when it fell from the spoon. And we can also see that in the visual pictures as well. And included with the data, I also just took some physical characteristics that I can notice visually. You can see that there was heavy ridging on the blood stain patterns. The ends, you see it's kind of like ridged up. And the real blood, it seems to stick together a lot more smooth and consistent with each other. And yeah. And for the last part of the experiment, I set up a cast off into impact spatter. So this is to represent someone taking a weapon, striking down on someone that already has blood on it. So you'll have like the fling from, say, a baseball bat, the fling from the baseball bat, the blood into the hit to a person, and the splatter that comes after it. We use the mouse trap to make consistent patterns from a meter away from the wall. And this was more of a visual test, but I noticed that in my testing in this picture right here, these splotches, very large splotches from the impact, and I decided to go ahead and measure those to see if the length of that splotch is consistent with each other. And you can see in the data points I'll show, this is the synthetic blood. You can see also that it's a lot fainter, it's a lot harder to see. But that's not as big of an issue when it comes to crime scene reconstruction, because you can use things like luminol to light it up and take pictures of that. But I will say the length, there was a difference. The authentic blood was shorter in length, caused a lot smaller of an impact pattern than the synthetic blood, which is another discrepancy I noted on my experiments. So in conclusion, I say the test, they did definitely show that there was a difference, especially on the passive drip. The blood spatter was almost double in size when compared to the authentic blood, the synthetic blood created. And I think that there should be more research into this. There already has been, to show more data so we can reach a better conclusion, because all of these tests, they were ran 3 each. For the passive drip, I ran 3 each from 3 different heights. So there was like 9 tests for each, but still, I think more research needs to be done into this, make sure that we're very consistent across the board with how we use synthetic blood in crime scene reconstruction. I say it's definitely useful though for educational purposes, because it is close to blood, but I think you can't really use it as a complete alternative to the real thing. And that is all.
And are there any questions that anybody has for Desmond related to his presentation?
I mean, like, how do they get, like, what is it? What's like the synthetic blood, like, what's it made out of? Oh, that synthetic blood, I couldn't find that out. I went online and researched it, but it doesn't really say what it's made out of. But I think I'll do some more research into that on my paper, because I mean, it was more of just a company and said synthetic blood, buy it, live research. But so many bottles of it in there. It doesn't even say it on the label, it just says where it comes from. So how do you get real blood for your tests? That is Mr. Willis magic. I don't know. I asked him for it, he delivered, and I'm very happy about that. Yeah.
Do not know.
Yeah.
Why are you two?
It's out of curiosity, and I don't know that the research indicated into this, but when you think it's the clotting factor that's in human blood.
Oh, most definitely. Yeah.
Why that makes a lot of the difference.
As I think, so the clotting factor, yes, definitely has an effect. And I would say that also goes back into the non-Newtonian and Newtonian physics. Because blood, it can change in your body as needed to be to like flow faster or if it needs to clot up. So I think that has a big effect on the viscosity. And as I said, I couldn't really figure out what the synthetic blood you used was made of, but I would assume that it's a liquid that doesn't have any clotting factors like that, especially because you're trying to store it and shelf life is much longer. So, and I think that has a big effect on how it created the patterns and all of that. So.
Okay. Are there any other questions? All right, Desmond, thank you very much.
For those of you in attendance, make sure you scan.
Oh, yes. If you're a student and you need to scan that, please, there's the QR code there for you to scan your phonics.
I scanned the one. We actually only went to the wrong. That's that my way next time.
Our other speakers are not here, so in fairness to them, I will stay in attendance. But for everybody else, again, Desmond, thank you very much for doing this. I would appreciate it. A very good presentation. Oh.
Desmond, like a little worry thought of this. So got it. You can never obviously. You got too much stuff. Your hair, it's rough. Get the thing cut. Yeah. We're all the floor. Good. I appreciate it. Yeah, Viper's definitely not. They're not locked in. They're not locked. Thank you. Thank you for going. Thank you. But I was like. I'm saving the. Listen, Derek. Thank you for coming. I didn't know we were.
Bye, take it easy. See you.
What'd you get? Hey, it's triple XL. Yeah.
Really? I'll take that back. I'll share it.
That's the one that you think,
I think they have. Yeah, they've got some of those in Melbourne, some kind of sizes. I can go in there and take a look. Yeah, I would appreciate that.
Oh, just go down on the second floor. You're done.
And then you got a bunch of others, a lot of
Size, small, or like 3X.
Thank you. I appreciate it.
Not a problem.
I didn't expect you to show up.
Yeah.
Yeah, she's come out. She's out right here. Nice. Very, very.
I'm gonna hang around here. In case you show up. I don't know.
Yeah, so I think they should relook at me.
That's where you want.
Yeah, I was, because I got the camera, like, I was uploading other pictures. I took onto there, like, regular ones, and I was like.
Oh, make sure, yeah.
I'll double check.
Okay.
Well, I know it's like in this, those two, but I think she says that they couldn't. Y'all might go through the race water yard here.
Oh, you're the smarter, you know.
Fair enough. All right, let's see.
You guys said you're here for Hannah?
Yeah,
Okay, is Hannah coming?
she should be. She said she was late though.
Yes, but I hope she's coming, please.
I assume so.
All right. I'm gonna get a hold of.
And I just wanted to make sure that I was,
Okay.
had the right title and all that.
Okay. Okay. I'm sorry to look at it. But I'm gonna get a hold of, I will get a hold of Dr. Previne and talk to him, okay? Yeah. Uh-huh. Mhm. Okay. Well, I mean, right now, they're. But I'll at least have a conversation. Video thing got zapped on this. No. That. No. There we are. Here. Ready? Excellent. All right, so we're gonna wait until the time, which we still have quite a bit of time. If folks feel the need to take a break, hopefully it shows up. If not, but I want to at least give her that opportunity to be here to present. So if anybody feels the need to take a break for a few minutes, you're more than welcome to do so. And I'll just keep this recording so I don't have to re-up it. All right, this event is to last till 2:40 p.m. If neither Hannah or Amy would get to present, show up, I will stop the session. Leave everybody. So, we have 20 more minutes. I'll wait around. If you want to take a break next time, then you're more than welcome.
Okay. Bridge. And they fought for the conservative. On and off, but on and out. But I would definitely. Yeah, yeah. Yeah, yeah, thank you. Right. Yeah, they can't. Well, and then they didn't. They didn't do that. They did great. Yeah, so they didn't think that. You'll show up, you'll have the information. Yeah, I'll reach out. You know, yeah, where you go? Yeah, they started, I don't even know the boss. I'll email her that too, then my whole.
Hello. Hello. Here.
Yes.
Yeah, I did.
Oh, good stuff.
All right. Okay.
Take a deep breath.
Did you email it to yourself? hopefully?
Yeah.
Yeah, yourself. Okay. Okay, I'm gonna hit a couple of buttons here for you. All right. This is Hannah Chadwell. She is one of our senior sociology majors. She's going to be presenting her findings on evaluating the relationship of screen time and mental health. How appropriate, since I'm on Zoom right now, we're going over mental health and screen time. Great topic. All right, actually, it is a great topic. So let me click the start video, and I got to click the share screen button. And then we're going to go onto there. Hopefully this thing, there we are, is up. It should still be recording. Yes, it is. Awesome. All right. Oops, let me click on that minus button. That out of your way. All right, and without further ado.
Okay, my name is Hannah Kate Chadwell. I am a sociology major here, and I did my research project over evaluating the relationships between screen time and mental health. So I took a self-evaluation questionnaire and I passed it out to several students on campus. The amount of students I had was just over 100, so that was my number I was working with. The objective was kind of just to see if there was like a correlation. If the higher the screen time, the higher the mental health system, or the higher the mental health symptoms. And I thought it was kind of appropriate because we're in the rise of like the digital age. So we are kind of the first generation that has this type of access to us, and the first type of generation that's being influenced and affected by the mental health and the stigmas that kind of come around with that. So it's a fairly new topic of research, and there's very limited data on what we do have right now. So evaluating these are very important to kind of get a better understanding for future research and help create a more of a support system for athletes and college age students, just because there's so little information about it that it's kind of hard to navigate it on like a larger scale with mass amounts of students. So basically my research objective was to see if there was any correlation between mental well-being, positive relationships, and like feelings of loneliness, which is kind of like the major mental health symptom that falls under a majority of mental health problems. So first I kind of defined mental health well-being. So the contribution of how we feel. So like your satisfaction with your life and how you are feeling emotionally, physically, how this plays into your relationships and your sense of purpose, your direction. So screen time is just any time spent on electronic devices. For the purpose of this study, I focused more on the mobile devices rather than computers and TV and everything. So for my participants, I have it was a little over 100. It was around 120, but I had to take out a few of them just because of the incomplete and the outliers. So for the purpose of this, I used 118 students, and the majority were females, average age of 20, and I had 42 males. So it skewed more towards the female side of this for the study. So for the method of data collection, I used a self-evaluating questionnaire. And on the demographics part of it, the last question was kind of the screener question to get the numbers for screen time. So it asked the demographics like background, basic information, and the last question asked the average screen time use of them if they had it accessible to their device. Then they could look on their smartphones. Most smartphones have a way of doing so. So after taking that, I used a series of basic questions of kind of like mental health screening questions that they use to help sort through what is diagnosed like clinically and what is like self-diagnosis. For the purpose of this, all of it's self-diagnosis. So the results of everything.
I was very surprised to find that screen time is not like directly correlated to well-being and positive relationships. It has more of a an individual counter to that. So it's subjective to the individual. So screen time is positively correlated to general levels of positive emotion. So there is some form of reward that gets looped into a behavior process that helps and reflects that screen time usage is directly related to not only positive emotion, but negative emotions as well. And screen time is also positively correlated to general purpose and satisfaction in life. So these two factors are very important to understand because it not only shows that the screen time has a direct effect on mental well-being, but it's not screen time itself. It's like a tool of measurement, and it's used. High screen time use does not necessarily mean you're going to have negative emotional and well-being states. It shows that many people that do struggle with higher levels of mental and emotional well-being problems do have a significantly higher usage of screen time, whereas people that don't struggle as much side by side does not. So neither screen time pleasure or meaning was significantly correlated to loneliness. So it's just the reflection of the positive emotion. There's no direct correlation to the negative emotion. So these are the graphs that I used. Basically under the variable chart is different forms of surveys. Like it has the DSM-5 has qualifications that you have to like fill out. So I kind of used the major questions and filled in like the data points to get these. It's like it has the average of it. So the mean is what we were kind of looking at for this. That's the significant information on that part. This chart right here, I thought it was important to include just because it looks at the actual mental health well-being things that people that did fill out or that do fill out the survey struggle with. So more as stress and anxiety levels are very high in student athletes, especially student athletes on campus that are still in their undergraduate program. Sleep is also very important in sleep quality because all three kind of correlate to each other and there is a direct relationship with all three. The higher stress and anxiety levels, the lower your sleep quality and your sleep quality is going to be. So difficulty sleeping, difficulty falling asleep, all of those kind of play into this. So basically what all of this means is not all screen time use is bad screen time use. It is more subjective, and the purpose and the intention behind the use of screen time. So the correlations between the two are significant because it shows that they do have an effect on each other, but they're not dependent on each other. And that's very kind of controversial to what a lot of mental health studies and sociology reviews have. This is also, I thought the research for this finding was different in comparison to many other research topics or similar research case studies, because my research was skewed more towards the females, and many of the research that is used and published today is more skewed towards males. So that helps kind of guide further research and clinical purposes to treating and diagnosing students with these struggles. And there's
sorry. So the strengths and limitations. The size sample for this study was majority student athletes and majority women. So there's also three points that need to be considered for future research and just to consider while looking over the data and the results for this one. So those are the participants were mostly with other, like if participants were mostly with other people during screen time use, that also affects the results because not necessarily the screen time use might not affect positive relationships or increase feelings of loneliness if screen time usage is in a group setting or if it is socially being used. So if participants were not alone during screen time use, they were using screens for online social interactions. So it counters the idea in the statement that screen time use increases feelings of loneliness and decreases mental well-being in that case, because some screen time use can be used for social interactions. So it gets that positive interaction without being in a social setting. Because when all of these are being considered, the human brain doesn't know if what is social interaction in person and social interaction online. Both of those positive reinforcements are the same biologically. So physically and emotionally, it's going to have the same effect if you're with people or if you're not with people. So if the participants were with other people, then this might have led to social relationships and higher loneliness. So this means that in a social setting or not in a social setting, that screen usage does have a direct correlation to social interactions, social relationships, and the positive and negative effects of your mental well-being. So counter to many research that is published, screen time does not negatively influence mental health and mental well-being in students, but it also has positive relationships. So it's like a pendulum, it has both sides. It's very, very unique to the individual in the case. So what this means for like future research is you have to be very, very specific in what type of social and screen time usage that you're evaluating. Because if you take into consider all screen time usage and all forms of social media and media interactions, you have very different fields like TV and social media on your screen time, like your screen mobile device, and computer interactions and social screen times on the computer are all three different categories, and they affect the behavior and the mental well-being differently. So, questions? These are just some of the
Great, excellent. Okay, does anyone have any questions? No? Cool. Well, thank you. Yeah, very good job. You're covering a topic that's, let's just say, vital to today's discourse and the things that are going on here. I'll log you out of this stuff right now, okay? I think I will not. We are. Ciao. You made it through. And if any of these shirts are not your size, on the second floor, at the end of the hallway, we have a mail room. There's a bunch of those shirts there, and this ranges from like small to whatever size, and just get the appropriate one if that one's not right for you. Okay. All right. With that concludes today's session. And I want to thank everybody for being here. It's appreciated. And I want to thank the participants, first Desmond earlier, and then of course, Hannah, rounding us up and taking us home. And I wish everybody a good day. Take care. Oh, yes, I'm sorry. There's the QR code scan for anybody. If you're doing this if you need attendance, please make sure you scan that. Button here.